Good morning. Let's start day 2 of the workshop. Good morning and welcome. I am Dr. Larissa Aviles Santa. I am the Director of the Division of Clinical and Health Services Research at the National Institute on Minority Health and Health Disparities. And I say hola, hello, good morning, buenos dias. Thank you for joining us on day 2 of the workshop. Before day 2 starts, I would like to take a few minutes or less than a few minutes to say thank you to all of you who logged in and participated yesterday, and to the panelists that delivered magnificent presentations on a very complex topic, to all the discussions that happened after each presentation and during the breakout sessions. I would like to very, very importantly acknowledge the work and the participation and collaboration of several persons from NIMHD and other institutes at the NIH. Especially, I would like to acknowledge Dr. Lynn Padgett, Dr. Dolly White, Dr. Carolina Solis Sanabria, Dr. Radha Daher, Dr. Shilpa Amin, Miss Simran Sidhu, Dr. Nancy Jones, Dr. Priska Mujuru, Dr. Vanessa Marshall, Dr. Michelle Dose, and Dr. Crystal Barksdale for their participation as moderators in the breakout sessions and the main sessions of the workshop. And of course, want to acknowledge Dr. Yewande Oladende and Dr. Sandania Wonum for co-chairing this workshop. So Dr. Deuce, the floor is yours.
Thank you. Greetings and welcome to day 2. My name is Dr. Michelle Dose, and I'm a program director in the Office of Cancer Survivorship at the National Cancer Institute. And really, it's my pleasure today to be your moderator for session 3, research design and data collection within the context of the healthcare continuum. We have 5 presenters today, and they include Dr. Stuart Gansky from the University of California, San Francisco, Dr. Andrea Sherrington from the University of Alabama at Birmingham, Dr. Marlene Kuneman from Leeds University Medical Center and Mayo Clinic, Dr. Kelly Williams from UPMC Center for High Value Healthcare, and Dr. Raj Shah from the University of New Mexico School of Medicine. The Q&A session will follow the presentation, so please type in your questions in the using the Q&A button that's located at the bottom of the screen during the presentation, and we will try our best to answer them during the Q&A session. So let's get started with Dr. Gansky's presentation.
Good morning. It's a pleasure to be with you today. I'm here to talk about the social determinants of health common data elements in the NIMHD Health Equity Action Network, which we call HEAN. And I, with my co-directors, Edwin Charbois and Kim Rhodes, I'm a director of our Research Coordinating Center. I don't have any conflicts of interest to declare. And objectives today, hopefully by the end, you will be able to categorize social determinants or drivers of health related to multiple chronic diseases by the NIMHD research framework's level and domain of influence, and also be able to evaluate the benefits of using a census-based place identifier, like census tract block group, rather than the Postal Service's zip code or even ZICDOS. The Health Equity Action Network's formal name or funder is Multiple Chronic Disease Disparities Research Consortium. So all of the projects are focusing on multiple chronic diseases. The overall goal of the network is to increase health equity in prevention, treatment, and management of comorbid chronic diseases if conditions where there are health disparities. And some of the diseases that were listed in the RFA are shown here. And these grants were issued after applications from joint RFAs being issued in 2021 as part of the Consolidated Appropriations Act of 2021, funded directly by Congress. The org chart for our coordinating center is shown here. And so we have the Research Coordination and Data Management Unit, with my associate director, Dr. William Brown. And we have been focusing on the common data elements, including the common data element and data harmonization working group. And but the network as a whole is shown here on this map throughout the US, 11 research centers, P50 centers, with the names of the centers shown here and the institutions at which they are based, as well as their logos of their centers or their institutions. Each center had 2 or 3 R01 level projects that were funded initially, and these are the 30 that were funded across the center. These are it's a word cloud of the titles of those projects, and so by the size of the word, so cardiometabolic being one of the larger ones, you can see how frequently those words repeated in the titles of the projects. Another way to look at it is to look at the chronic conditions, the behaviors and the populations and the kinds of interventions that the projects were using. And so, for example, cardiovascular disease comes up there. But since they all had to focus on multiple chronic conditions, we can also look at how they occur jointly or how they are being studied jointly amongst the projects in the consortium. So, for example, cardiovascular disease, you can see how many projects overlap with hypertension, with sleep problems, with type 2 diabetes mellitus, obesity, stroke, and so on. And you can see the large number of cardiometabolic disease studies and cardiovascular disease studies compared to the smaller number of liver and kidney diseases being studied. The aims of the RCC are shown here, and I'll be focusing today talking about the second aim, implementing the heme-wide common data element development, collection, integration, curation, analysis, and sharing. And so we have a working group, as I mentioned, and the charge to the working group was to recommend a set of de-identified common data elements as required by the RFA and terms of award to the steering committee of the consortium. So these had to be de-identified. That was one of the stipulations in the RFA, as well as particular emphasis on collecting social determinants or drivers of health as common data elements. And we also wanted to be sure to include measures of comorbidities or quality of life. And so the comorbidity measure is Charlson for those that are using electronic health record data and Sangha for self-reports. And then the other tasks of the working group relate to data transfer and harmonization. So these RFAs came out. The centers and projects had already been working in many cases for a long time with these community partners to co-design, co-develop interventions to alleviate the health disparities that are being observed in their communities. So in many cases, centers had integrated social determinant of health screeners in their centers across all their studies and focusing their interventions to directly build off of what was being screened. So here we have the map and collapse. We first started by taking an inventory of the as one option of how we could move forward as a coordinating center and a work group. And so map and collapse, we took stock of what the plans were of each of the projects and at each of the centers. But this became rather unwieldy. There were some unvalidated items. Items were not very comparable across centers. But they were a little more tailored and targeted and not so lengthy. But it would have taken a lot more time to map them, and it would have been not a very good mapping. An alternative would be to use an existing toolkit in entire kit or collection or instrument. And these are validated scales. They would have made comparability the best across the studies, but would have resulted in lengthy CDE list and would not be tailored. So we took this middle ground where we identified parts of existing toolkits, collections, and instruments and integrated them with some additional measures from the centers or projects. So we came up with mostly validated items, more comparable although some are not entirely comparable, and brief. But there's some issue in that they're not tailored. But this is the way in which we resolve the issue of resolving the issue of each of the centers having already worked with their communities. They still need to take these back to the communities and get community buy-in, and that took quite a bit of time. And we made modifications based on feedback that we got from the communities. So we reviewed Phoenix Core, Centers for Medicaid and Medicare Services, Accountable Health Communities, Health-Related Social Needs Screener, All of Us, SDOH module, and Kaiser Permanente, your current living situation, as well as others that are part of the Siren group at UCSF, based at UCSF, which reviews SDOH screeners used in primary care. We took those elements and we based it on a framework from Davis and Shanley of looking at environmental factors, social factors, and health factors, and then mapped those onto the NIMHD research framework of domains of influence and levels of influence. And so they map on rather well here, shown here as the names of the domains, and shown here as some example items, common data elements from the draft lists that we produced. And so that was a way of ensuring broadness across these domains, but being brief and not overburdening members of the community and participants. So we reduced down. It includes the Promise Global 3 quality of life item, and as I mentioned before, the Charlson or Sangha as comorbidity index, and reduced down from a very large number of the entire SDOH toolkit to our 44 items, taking up 164 fields in REDCap, and not everyone would have to answer all of those fields because there's some conditional branching that's involved. These are translated to Spanish, Vietnamese, and back translated. And then they were brought by the working group members back to their projects and their centers for assessment. And like I said, in some cases, items were removed or made optional and no longer part of the required. And so that's how we ended up with 44. And we encourage people to get that community feedback, perhaps make word modification changes for cultural appropriateness, and but leave in a way that we could still map to the concepts. And so we have this data transfer process, and then we have been using some semi-automated methods to do some of the matching and the mapping, but we're in the process of continuing that work, and we'll be building the data warehouse with the mapped items. So the transfer tiers that we have include individual ones, social determinants of health, global health, and comorbidities, as well as area level SDOH measures. And we're in discussions about adding some optional individual measures. Here are a couple examples of the Global 3, Promise Global 3 item, and a disability SDOH measure. This is our consortium progress to date. So more than 26,000 research participants are planned to participate or be enrolled. And so far we've had 9 data use agreements executed. 4 projects have transferred data for over 400 records so far. I also want to talk about our supplement that we received to prepare the data warehouse to be AI ready for the NIMHD and NINR share data repository, which is being created with the goal of bias mitigation in AI analyses. And so we are in the process of developing community archetype codes instead of zip codes or census tracts, so that we would be able to keep the data de-identified and to de-identify or anonymize the census tract data in a way that would keep the community anonymized. And then we're also working with community advisory board members to develop guidelines about involving community members in data collection for reuse for repositories and AI analyses. when I had the pleasure to meet with our advisory board for the first time more than a year ago, our networked community advisory board, I talked about these neighborhood measures, and they were quite interested, particularly in items relating to the food environment, food deserts, food swamps, environmental exposures, and sufficient resources, including recreational spaces. When we talk about place and we talk about these measures, these neighborhood measures, often you see people using zip codes or ZICTAs, zip code tabulation areas, but those cut across state lines in some cases. They can change multiple times a year. They don't have a consistent number of people in each of them, and so there's a lot of downsides to using zip codes and ZICTAs. And it's much better to use a true measure in the census tract, in the census measure that is nested, such as census tracts or PUMAs. But anything that's smaller than the county level is protected health information, and then the data are not de-identified. So we have to remove the geolocation. In addition, there's some important examples of negative impacts of data reuse, not on individuals necessarily directly, but on the communities themselves. And so it's another reason to keep the communities safe in that way, their data safe. And so what we're doing is we're developing a crosswalk file of community measures that the research centers and projects will connect to, remove the geolocation, run it through a de-identification anonymization process, and then send that information to the coordinating center to be put into the database. We have all of our information on our website for our consortium, and our Common Data Elements webpage also has the current versions and past versions and change files in multiple formats of the Common Data Elements, and we're happy if others could use them. I want to end by saying that Common Data Elements in community-based participatory research or community-engaged research is not a field of dreams. If you build it, it does not guarantee they will come, and in many cases they won't. So if you build it, will they come is really the watchword here, and that only comes from working closely with the community. We've already begun discussions when it comes to the optional items about what questions the community have, and therefore what should be collected in the consortium as optional items for additional information. Thank you very much for your attention, and I look forward to the panel discussion.
I'd like to thank NIMHD for inviting me to come and talk with you guys today about some of the work we're doing in the rural South to address cardiometabolic disparities. Before I talk about our own work, I just want to give a little bit of background for context. This slide shows diabetes mortality rates across levels of rurality and time, starting back in 1999. You can see that the rural areas are represented by the yellow bar. In most of these cases, you can see the yellow bars at the top. I want you to take a couple of things away from this slide. One, diabetes mortality rates have declined in some areas over time, but that's not necessarily the case in rural areas where any reductions in time seem to have plateaued around 2010 and actually seem to have been increasing. You can see in the total panel on the left. And then if you look to the right, you can see that that is in large part driven by outcomes that we see in the South, where there's definitely a divergence between rural and micropolitan mortality rates compared to other regions. And I've chosen diabetes here as an example, but these trends are similar in a lot of other chronic conditions like heart failure, cardiovascular disease, and other chronic conditions. We do a lot of our work in the Alabama Black Belt, which is a region of the country that is very rural. It's the southern part of Alabama. It's 18 county swath. It's historically named for its rich, dark soil. It's also the region of the state that had a high prevalence of slavery prior to the Civil War. Today, there's a high proportion of the population has a high proportion of African Americans. It's on average 56% of the population is African American, with a range by county from 23 to 81%. Poverty rates are also quite high in this area, 25% on average, but again, a range of 20 to 30%. And we know that rates of hypertension, diabetes, obesity, and related complications are also the highest in this region. So what contributes to these disparities? There are structural and system level factors that you can attribute to a lot of the disparities. This conceptual framework demonstrates the socio-ecologic framework, and you can see each of the levels of influence ranging from individual, interpersonal, organizational, community out to public policy that are known to exert an influence on health and health outcomes, with social and structural determinants, examples of those, interspersed across and exerting influence across the levels. We know that adverse social and structural determinants in rural areas, such as lack of access to healthcare, lack of access to education programs, lack of access to fresh fruits and vegetables, long distances, limited transportation, all contribute to disparities in health outcomes. It also makes conduct of research in rural areas challenging. So I'm going to pivot now to talk a little bit about two projects that we've been doing in Alabama and North Carolina that I think we can use as a way to highlight some of the challenges and hopefully solutions that we've encountered over time. The first one I want to talk about is called the Southeastern Collaboration to Enhance Blood Pressure Control. This is a PCORI-funded study that was administered by NHLBI. It's a real-world 4-arm cluster randomized implementation trial that took place in the Alabama and North Carolina Black Belt, which you can see demonstrated in the map to the right. This was a collaboration between UAB Medicine, Eastern Carolina University, the UNC Chapel Hill, and Weill Cornell Medical School. Our goal was to test 2 evidence-based strategies in 69 primary care clinics, rural primary care clinics. The first one is practice facilitation, which you could think about as coaching at the systems level. Practice facilitators come in and help practices use their own data to implement quality improvement initiatives around evidence-based guidelines. And then peer coaching, sort of as the name insinuates, it is health coaching that's often delivered by lay individuals who typically have a health condition that they are trying to have the same health condition that they're trying to assist others with. So for example, people with hypertension assisting others with hypertension. We enrolled 1,600 participants in this study, 61% of whom were women. Roughly 40 had comorbid diabetes and 38 require help reading medical instructions, just to give you a sense of the population. In our main results, we saw no differences in blood pressure control in any of the trial arms compared to usual care, but in pre-planned analyses, we did see improvements for individuals who were young, less than 60 years old, for peer coaching. We did not in this study assess hypertension at the practice level because there was no rigorously collected practice level blood pressure control data available. So that takes us to the next study, the Alabama Cardiovascular Cooperative, supporting cardiovascular risk reduction in primary care. This is a 3-year study. It's ongoing. That was funded by AHRQ. And the goal here is to test the impact of a practice facilitation intervention on cardiovascular risk reduction, and particularly looking at risk disparities in risk by race. Our primary outcome is at the clinic level. We're looking at 2 outcomes, actually, hypertension control as well as referral rates for smoking cessation. And this is a multi-sector partnership between the Alabama Department of Public Health, UAB, Auburn University School of Pharmacy, the Alabama Primary Healthcare Association, and QSource, which are both nonprofits that are doing work around practice facilitation and coaching for clinics, primary care clinics. And as I mentioned, this is ongoing. This is a map of the clinics that we've enrolled. We did initially contact 417 practices. 51 declined to participate. We had no response from 308 practices. We ultimately enrolled 51 practices, 28 of whom were federally qualified community health centers, and 23 were non-federally qualified community health centers. We felt like it was important to try to get equal representation or close to equal representation of both. This slide just demonstrates the blood pressure control rates by clinic, by race at baseline. Overall, we had a control rate of 52% across all the clinics. Control rates at baseline were lower among Black patients at 50% compared with white patients at 56%. You can see trends in the slide there. Obviously, there aren't a whole lot to the left over up at 90 to 80%. Most clinics had control levels of 60% or below. And almost all the clinics, with the exception of one in the middle that had only one African-American patient, had control levels that were higher among white patients than Black patients. So I'm going to pivot now. That trial is ongoing. I want to pivot here to talk some about challenges that we've encountered through the implementation of these studies. The first challenges relate to recruitment and engagement of primary care clinics. First of all, clinics are extremely busy and face a lot of competing demands. This was especially the case during COVID, coming out of COVID. Phone calls, emails, faxes that we would use as an attempt to engage with clinics often went unanswered. And then with relation to sustained engagement, turnover is very common. In the ALCC project I just described, 17 of our clinics had a change just in their practice champion, which is sort of our named go-to contact within the clinic, who our practice facilitator typically works with. This makes implementation evaluation difficult. As pragmatic trials, one of the goals that we have for these projects is really to try to understand the context in which they're occurring so that we can figure out what makes things work, what fits into the clinic flow, what is going to be sustainable, what isn't going to be sustainable, and why. But that requires getting in and talking with clinics about and people in the clinic about what's happened. So surveys and interviews, but that only works if you can survey and interview people who have been, a part of the project. And so turnover makes that really, really hard to do. So some of the solutions that we've tried to put in place to mitigate the challenges, in-person meetings with providers and key leaders is the most effective strategy we've found to recruit clinics and to continue along with engagement. It gives people the opportunity in person to ask questions and for you to build rapport and to get good buy-in. Also, we identify practice champions as well as a backup, and sometimes two, so that when we do face turnover, there's some institutional memory for the project and the initiative. We do find that bringing patient education materials, pens, Post-it notes, things that the clinic can find useful, as well as food, always helps us get a foot in the door and get a conversation going. In addition to trying, obviously, to sell the value of the intervention, I think most people can get behind the value of the intervention, especially when you're sitting there in the conversation. But once you leave, anything that you can leave behind that can continue to be helpful goes a long way. And then frequent contacts. So trying to do in-person contacts as much as possible. Monthly is what we shoot for, but then with phone calls and emails in between to try to maintain continued engagement. In terms of challenges with data collection, I'm going to focus primarily on data collection with the EHR, because that's a lot of what we did, particularly in the last project. EHR variability is huge. So across the 50 projects we have engaged in the ALCC, there were 10 different EHRs, and you can see them shown there on the figure on the right. Even within the same EHR, if someone has NextGen, for example, which is the most common, there's still different versions and people buy different packages. And so you're still grappling with some of the challenges related to having different EHRs or different capacity. It's very time consuming to extract clinical level data. Sometimes you can't do it. There are pre-programmed reports, but those don't always include important variables like race. If we can't look at race, we can't measure disparities. If we can't measure the disparities, we can't try to address them. And then some EHRs aren't certified, and so they don't even have pre-programmed reports. So you're trying to build reports in real time. And then that's sort of the first order. The second order complication is merging the data. So cross-site data management is a challenge. In our case, we worked with an outside vendor to try to pull data together to build dashboards that we could then give to the clinics as part of the intervention. But it was hard. They were in North Carolina. They weren't here. They were disconnected from the clinic, so we didn't, have it was hard to develop a warm handoff. And then the return on the dashboards was slow. So sometimes clinics didn't even get those until the third, or the fourth quarter. Solutions, all I can suggest is to be flexible and try to create workarounds. Sometimes when we couldn't extract data, we had to do real-time data polls, looking at like the last 100 hypertension patients that came in, and using those blood pressure dates. We tried, if you can build in EHR vendor fees, if it's great, it can help them build out reports, and I think can add to the potential for sustainability. And then obviously involving folks with IT expertise on the team is important. We ran into a lot of challenges with relation to implementation. It's challenging to focus on one cardiovascular risk factor at a time. We found that few clinics implemented the tobacco-related QI activities in the end. Those that did tended to do it in the third quarter or fourth quarter. Similarly, there is variable capacity for quality improvement initiatives. Some clinics have very few staff. They're stretched, and so they really have a hard time doing some of the activities that are required to get these QI initiatives done. It's also hard. One of the activities we tried to promote was self-management support, but when there are limited community resources available, it's hard to encourage folks to reach out to community resources to do those efforts. So for example, if you want someone to work on weight loss and diabetes prevention, but there's no diabetes prevention programs around, you can't connect them with any. We've tried to overcome that a little bit by building out a website that's demonstrated there on the right, that keeps a real-time log of all the local activities and resources available, in the hopes that we can connect people to those. But that, still remains a challenge. And then tracking those referrals and closing the loop on those referrals is also a continued challenge. So takeaways, sorry, that was really fast. Takeaways: social and structural determinants that underlie rural and urban disparities also make the conduct of research in rural areas a challenge. Recruitment requires personal connections and in-person visits. That's most effective, but that takes a lot of time. Often it takes us 2.5 hours to get to a clinic one way, and money. And so, we're sending multiple staff, renting a car. So building plans in for that on the front end is helpful. Continued engagement over time is essential. Data extraction and management requires specialized expertise. You have to include those kinds of folks on your team. And then finally, small practices with modest support and staff and challenging EHR systems are going to need additional sustained support for data capture and intervention programs focused on multiple chronic conditions. So with that, I just do want to take a minute to say thank you to all of the folks on our team who've made this work possible, and I will turn it back over to others.
Hi, my name is Marleen Goedeman. I'm an assistant professor of medicine at Leiden University Medical Center in the Netherlands, and also at Mayo Clinic in Rochester, Minnesota. And today I would like to talk to you about making care fit and promoting equity through encounter research. To start, I have no potential conflicts of interest to report. I do not receive any funding from for-profit organizations. Still, for too many people, their care plans are designed without fully accounting for who they are, the lives they live, what matters to them, or what they aspire to achieve. In other words, these care plans are designed for patients like this, rather than for this patient. In the next 15 minutes or so, I would like to discuss some of our work and views on research on optimizing care, especially in chronic conditions or multiple chronic conditions, when either care or life, or the combination of care and life, is complex. Many healthcare models present key elements of healthcare systems that encourage high-quality care. For example, the chronic care model focuses on the community, on the health system, self-management support, decision support. And this means that these models focus on managing care of groups of people, most often with one specific chronic condition, such as diabetes or heart condition. And these models try to streamline processes of care, of collaboration or communication between clinicians or departments or facilities, or streamline scheduling of care. And in managing care of these groups of people, we try to promote equity, to address injustice, overcome any obstacles that people may have to have access or get the care that they need. Although valuable, I think that these top-down approaches of organizing the system fall short of meeting the needs of people with multiple chronic conditions, especially of those who are more vulnerable. Because even if we imagine that we use these models to design well-organized healthcare systems, and all patients actually have access to care, for example, they are able to get into an appointment with their clinician, or they have access to the interventions, as soon as they are in that encounter with their clinician, they work together to design a personal care plan that is supposed to fit well for that particular person. My work focuses on these encounters, on this micro level, and on how to improve healthcare through improving these patient-clinician interactions. Why is this so important? Well, just a few examples. 1 of every 5 patients indicate that they did not receive their preferred care. This suggests that they have care plans that do not fit them well or optimal. And 3 of every 4 young adults with type 1 diabetes indicate that their investments in healthcare are unsustainable over time. So at some point, aspects of care will not be implemented, or they will be implemented, but only at the cost of those things that make life worth living in the first place. Even if we use interventions, if we build interventions into EPIC to promote collaboration between patients and clinicians, such as patient decision aids or conversation tools, we see that not all patients have access to these interventions. For example, when implementing a tool across a healthcare system in the US to help make decisions about using statins, research showed that the tool was actually offered less to women and less to people of color. So just organizing healthcare systems and making these interventions available through EPIC does not necessarily promote equity. About half of all the variation seen was clinician-driven. In order to find out how to overcome these obstacles, we need encounter research. We need insights into how patients and clinicians collaborate and make decisions about health and care. We call this process of collaboration making care fit, which is an ongoing and iterative process in which patients and clinicians uncover what the medical and personal situation of that patient is and figure out together how to best improve it. For this, they work together to find out how to maximally respond to the situation and priorities of that particular patient and how to minimally disrupt their lives, those things that make life worth living, and their communities of care and loved ones. This means that we need to take into account, both in these conversations, but also in the healthcare models that we design, both the biology of a patient and the biography of a patient. And there already is quite some work on social determinants, which is linked, but these are less actionable at the clinical level. So in order to see the value of healthcare models for designing care plans on a patient level, or to identify how to adjust models or design models to take into account what matters most to patients, we need to determine what measures to use and what outcomes to assess. And here are some examples of possible methods to research what happens in that black box of clinical encounters. First, there is encounter observations, either in person or through audio or audiovisual recording of encounters. Although some people find this slightly uncomfortable, people usually tend to forget that they are observed during an encounter or after a few recordings. And also, we often see quite low numbers of patient involvement in encounters, suggesting that even though people know that they are observed, there is much room for improvement. These encounters can be coded using quantitative coding schemes, counting what happened and how often. For example, with validated coding schemes, which also allow for comparisons between studies or within a study between study arms. In this particular study, we introduced a conversation tool for patients and clinicians to discuss anticoagulant treatment. We used the validated option 12 scale, through which we showed that patients were more involved when using the conversation tool compared to usual care. Encounters can also be coded using qualitative methods, using programs like MaxQDA, NVivo, or Atlas TI, which allows for an in-depth description of how patients and clinicians interact and collaborate. After encounters, we can ask patients to reflect on their interaction and on their decided upon care plan. We have used patient written reflections, providing narratives on why their care plan made sense to them, but also video reflection, where patients or clinicians watch their own video recorded encounter, and they may stop the video, for example, at a moment where they had not shared particular information with each other, or when something happened that made them feel uncomfortable, or perhaps that made them feel cared for. And lastly, to assess the impact of care, chronic care specifically, on people's lives and what people actually need to do to implement their care, we used a method called photo voice. In this method, people send us real-life pictures of their daily lives, and we can understand better how care and life are aligned. What aspects of care may be adjusted because life is lived, or what aspects of life are adjusted because of people's care. And this may well be part of the data that we need to see whether these issues are also discussed during clinical encounters when designing care plans, and also whether healthcare models sufficiently take these aspects into account when focusing on managing care for groups of people. As I said earlier, to improve patient-clinician interaction and to ensure that healthcare models support optimal collaboration, it is crucial to find both the right methods and the right outcomes to inform such models. To aid researchers in determining relevant outcomes related to patient-clinician interaction and to their efforts of making care fit during clinical encounters, we systematically reviewed the literature. We screened over 13,000 papers and composed a library of over 1,200 measures available to assess aspects of making care fit. This library is ordered by the dimensions relevant to making care fit, so whether it maximally responds to the patient's unique situation and priorities, minimally disrupts their lives and communities of care. But it is also ordered by the behavior that is actually assessed in these measures. So, for example, are we aiming to assess efforts of providing information or making a human connection? This may help researchers in determining what outcomes fit best with the purpose of their project. And this paper and the library are available open access. Lastly, we need to be careful to select the right measures and outcomes, and we need to be careful in interpreting the data as we are trying to improve the quality of care. In this paper called Measurement with a Wink, we have reflected on some common pitfalls in quality of care improvement. This included gamification of measures, where we may see higher scores if people know best how to get the points rather than to improve the underlying construct. So, for example, you may be rewarded as a clinician for prescribing a statin to a patient while actually the patient is not willing or able to take them. Or for getting an HbA1c of 6.9% in a patient with diabetes who is now living in fear of recurrent hypoglycemic episodes. The paper also included over-reliance on proxy outcome, using, for example, patient knowledge as an outcome or indicator of successful patient involvement, which may be linked, but is not exactly the construct that we're trying to assess or improve. Gaming these measures reduces the freedom that patients and clinicians have to make care fit. And in choosing our measures and outcomes, we need to ensure that our assessment aligns with our goals, for example, promoting equity in healthcare. So to conclude, in designing and testing healthcare models to manage care for groups of patients, we need to take into account how helpful these models are to aid interactions between patients and clinicians as they co-create plans of care. The Making Care Fit framework can help us innovate research and model design in chronic care. Relevant research methods are encounter observations, which allow for quantitative and qualitative analysis, patient reflection with or without video feedback, and photo voice to assess the impact of care. Importantly, when choosing the right outcomes and the right measures, we need to avoid measurements with a wink, gamification of outcomes to provide the illusion of improved care. Eventually, by improving patient-clinician conversations, we can improve the quality of care. Thank you.
Hello, my name is Kelly Williams, and I am thankful and excited for the opportunity to be a part of this workshop. To start, I briefly want to share the context of my role within the health system, providing a lens through which I'll address today's discussion. As the Director of Research and Implementation at the UPMC Center for High Value Healthcare, I operate within a non-profit research organization that is owned by UPMC and situated within the UPMC Insurance Services Division. UPMC stands as an integrated delivery and finance system, embodying the principles of a learning health system. Part of the center's core mission revolves around conducting research and driving quality improvement initiatives to address the quintuple aim for healthcare improvement. One of our center's funded research contracts is the focus of my presentation today. Our objective is to assess the impact of 3 health plan level care management delivery models for individuals living with multiple chronic conditions. During this presentation, I'll delve into the study's interventions and outcomes, highlight 2 ways in which data can optimize care delivery and patient-centered outcomes, and conclude by sharing an implementation success story. When we initiated the study in 2018, there was a resounding call across the healthcare landscape urging researchers to focus on system-level interventions to improve care for patients living with multiple chronic conditions. The need was clear. We required studies conducted in real-world settings, emphasizing strategies that could broadly be applicable to diverse patient populations and reliably implemented across health systems. At that juncture, no head-to-head trials had yet compared the effectiveness of system-level interventions in supporting the delivery of evidence-based integrated care for adults with multiple chronic conditions, whether in the general population or among Medicaid and dual-eligible beneficiaries. Now, I'll move into the specifics of our study interventions. Healthcare payers have numerous system-level features that can be used to create a patient-centric ecosystem that fosters better health outcomes and efficient care delivery, especially for those living with complex health issues. 2 critical features that really stand out are, 1, a personalized service design that involves highly trained and multidisciplinary care teams capable of addressing diverse aspects of patient care, and secondly, technology-supported tools and resources that can provide access to care management support through digital tools. So on this slide, you can see our study focused on 3 distinct ways of delivering integrated care management: high-tech, high-touch, and optimal discharge planning. I'm actually going to start by explaining the bottom row first. The UPMC community team played a pivotal role by implementing all 3 interventions outlined in the figure. This dedicated care team consists of registered nurses and licensed social workers and counselors. These professionals bring their expertise in care management, ensuring the development and monitoring of individualized care plans, and play a crucial role in providing patient education, supporting chronic disease self-management, and facilitating linkages between members in medical, behavioral, and social services. Now, this figure again provides a high-level summary of the nuances of care delivered across the 3 intervention arms. It's important to note that for all 3 interventions, care managers met with participants in their home or community setting for their initial visit. So starting with the left column, the high-tech approach involved remote patient monitoring, I'm going to say RPM throughout the presentation, and telephonic contacts. Remote monitoring included video visits and condition-specific text message check-in questions that occurred daily, weekly, and/or biweekly, depending on the condition. The duration of care was 4 to 12 months. In the high-touch approach, both in-person and telephonic modalities were utilized, and the duration of engagement mirrored that of high-tech. The last column, optimal discharge planning, involved that initial in-home visit and then telephonic care management delivery. The duration of time was shorter, with 2 weeks of care management, and if necessary, an additional 2 weeks were allocated for resource collection and seamless transition. The primary goal of our randomized trial was to compare the effectiveness of the 3 interventions on several patient-centered outcomes. So that's the first aim listed here. We meticulously designed our study to have sufficient statistical power to allow us to examine the differential effects of our interventions across important subgroups on our 3 primary outcomes, which were 90-day readmissions, patient activation, and health status. Subgroups included factors such as race, age, illness complexity, and comorbid behavioral health conditions. Last, but certainly not least, we had a qualitative process aim. Our focus here was on learning about barriers and facilitators to efficient and effective implementation. Understanding these factors is crucial for successful integration and scaling of evidence-based care practices. Okay, so moving into our target population. Our population consisted of Medicaid or dual eligible enrolled adults aged 21 years and older who are living with multiple chronic conditions. Participants had at least one physical health condition and at least one additional physical or behavioral health condition. Many conditions were included in our eligibility criteria, so I'm going to name a few examples: cardiovascular disease, hypertension, asthma, chronic obstructive pulmonary disease, diabetes, depression, serious or persistent mental illness, and substance use. Participants also had been discharged from an inpatient hospital stay within the last 30 days and were identified as having high and/or rising healthcare needs and being at risk for unplanned healthcare use. It's important to note that English and Spanish speakers were eligible for enrollment, and really our comprehensive approach for eligibility really allowed us to study a diverse group of individuals living with multiple chronic conditions, ensuring that our findings would be applicable across different patient populations. And moving into some data details, the first and second column here showcase our primary and secondary outcomes. The third column displays our qualitative and process data sources and outcomes. As you can see, we collected 5 different self-report surveys from each participant. This data was collected at baseline, 3, 6, and 12 months by a team of 2 to 4 research coordinators. We achieved survey retention rate of over 80% for participants at each time point. Additionally, we also collected several claims-based outcomes, and we really obtained these healthcare utilization claims data through 2 sources: the UPMC Payer Claim Data Warehouse and the Pennsylvania Department of Human Services for members insured by other managed care organizations for behavioral health services. And due to privacy and data sharing policies, we of course recognize that not all claims related to substance use diagnosis or behavioral health were obtained for our analyses. I also want to note that we obtained informed consent from our participants prior to using any data for research purposes. And in the context of implementation science in this last column here, I'd like to highlight in the next couple of slides 2 data collection techniques that are listed here. But for now, I just want to say that these types of data are incredibly important to collect for any research study or evaluation. They provide insights into how interventions were delivered, perceptions of the care provided, personal impacts, and can also eliminate areas for improvement in implementation fidelity. Okay, so for our first data spotlight, for our qualitative data collection for the study, we partnered with qualitative researchers at the University of Pittsburgh who conducted and analyzed 60 provider interviews and 144 participant interviews. Now, these interviews were all collected at 3 different time points throughout implementation. Interview themes focused on quality of life, impact of conditions and symptoms on daily activities, experience with care management, and preferences for mode of care management delivery. On this slide, you will find 2 quotes. The first is from a participant who discusses what their care manager supported them with, including care coordination and medication support. The second quote is from a care manager who has a participant in the high-tech care arm. They are talking about a participant with diabetes who enters their blood sugars through an RPM text message daily. The care manager uses this information to discuss diabetes care management goals and care coordination. And as a qualitative mixed methods researcher, I wanted to showcase these abbreviated quotes because I believe it's essential to elevate the words of your participants in the implementation team. These insights from the interviews are incredibly important to the work that we are doing, and the information provided by these participants and our care managers will directly inform decisions we are making on how to best tailor and scale care management services. I also should note here that we are actively working with our partners to publish these results. Okay, and this slide focuses on one major piece of data collected from care management charts: the problems care managers and participants identified at the start and throughout care, and the interventions care managers delivered to address co-identified problems. Having a uniform system for logging care interactions and care delivery is essential for understanding services participants receive, as well as to track fidelity of the care standards. All staff were trained on how and when to document, and supervisors performed routine check-ins to review care provision and documentation. This type of data provides us insights into how different types of care was delivered more or less often across our intervention groups. So really, while care delivery was actually consistent across our interventions, if it was not, we would have been able to use this real-time data to inform our qualitative interviews. In this hypothetical case, interviews could be expanded to help us learn more from care managers about any barriers to certain types of services delivered via in-person, through RPM, video visits, and telephonically. Okay, and so I just want to share a couple more slides before I wrap up. I'd like to share an example of why it's valuable to track as much information as possible during a research study. Doing so can lead to important insights about how implementation is progressing. For our study, we were acutely aware at the beginning for the need for continued stakeholder engagement, collaborator feedback, to promote effective high-tech care implementation. At the time, there was really a lack of research on the challenges that occurred when implementing digital care with traditionally underserved population and those with high burden medical conditions. So in the box on the right, you can see the types of data our team collected outside of the data we collected to address our 3 study aims. We tracked all study-related calls from participants and care managers, the meeting minutes from our clinical team meetings, interviews with care managers, and feedback from our patient partner work group. As this information was reviewed and discussed with our clinical team and other collaborators, several technology-related challenges were prioritized and solutions were identified. And so the one I'm going to talk about now, the difficulty identified was using a smartphone and different components of high-tech care. And really, to build equity in digital care accessibility and to support better digital care engagement, we co-developed 2 flexible and scalable solutions. The first was the development and implementation of in-person or telephonic technology support visits. These visits for the study were led by members of the research team to ensure the solution did not detract from case management time. During visits, members of the research team would help participants learn how to use their smartphone, as well as how to conduct a video visit and click on text message links to answer condition-specific remote monitoring questions. The second solution was a participant-facing technology user guide, which a page example is here on the right, that really in text, images, walked participants through common smartphone functionalities, as well as how to use the remote patient monitoring platform functionalities. These tactics led to measurable increases in successful RPM engagement, which was really neat to see. Okay, and so I just want to take a moment to say that this work and the work represented in this presentation would not have been possible without our participants, care managers, our collaborators and advisors, all of the members of our research team, and my fellow investigators. And I just want to have a special thank you to Dr. Dan Swayze for leading this work, and to Sarah Marquardt, who has invested so much of her time and expertise working on this study with me since 2018, and is also responsible for many of the engaging graphics used in this slide deck. So thank you all for taking the time to be here today, and I'm really excited to learn more from everyone during the Q&A and the remainder of this workshop.
Hello, good morning to you all. Thank you for inviting me to present during this symposium, which is a virtual kind of presentation for me to talk about culturally congruent healthcare to reducing health disparity in our indigenous population. I'm Raj Shah from University of New Mexico School of Medicine. Today, my learning objectives are to really brief you about indigenous people here in America and their health disparity, how the healthcare challenges in Native Americans are met. And one of my model I have, which is community health workers to enhance the clinical care, which is same as, if you have heard about Project ECHO, it's an ECHO model. And I'll briefly talk about results from culture center approach in one of my PCORE study results. So let's go back to talk about American Indians and Alaska Natives and their health disparity. So if you know about Native Americans here, they have experienced lower health status when compared with other Americans. They have lower life expectancies and disproportionate disease burden, which still exists today because of inadequate education, disproportionate poverty, discrimination in the delivery of health system, and cultural differences. These are broad quality of life issues rooted in economic adversity and poor social conditions. There are 573 federally recognized American Indians and Alaska Native tribes and their descendants who are eligible for one HMO, which is Indian Health Services. If you look at some of the other facts about Native Americans and Alaska Natives, as per the US Census 2000, they were at 2.6 million, which is 0.9% of the American population. However, their growth happened so much within last 20 years, where as per 2017 census, their population is now 5.6 million in America. During this last 10 years, they grew 26% compared to the US general population. The birth rate, however, is 25.7 versus 15.5 per thousand for general population. Median age is 28 years versus 35. So it's a young population. Their life expectancy, though, is 4.4 years less than the rest of America. Their geographic distribution, they are mainly in west part of the America, but they are all over. I mean, they are in Midwest, in South, and Northeast. The distribution of 10 leading causes of death, which will surprise you, more than focusing on our chronic conditions and disease and all. The first thing is disease of heart, then cancer. But the third one, if you see here, is accidents, which are unintentional injuries. And then fourth one is natural, which is diabetes. And then you can see chronic liver disease, chronic respiratory disease, stroke. And then another major is suicide. So suicide and accidental injuries are two major part in first 10, leading causes of death among Native Americans. We go further into socioeconomics. High school education is less compared to US general population. College is really less, about 8.9%. Their unemployment rate is really high compared to America. If you look at male versus female, 6.4 to 16.4 or 6.2 to 13.2. Median household income is really half of what the America earns today. So considering the poverty rate, they are really poor of the poorest in this country. Now, if you look at the disparities about the disease itself, highest tuberculosis, highest use of alcohol, that may actually can think about, the unintentional injury or accidental deaths and suicide. Motor vehicle crashes are 229%. Diabetes is another highest thing. Homicides, 100%, suicide, 7%. Infant mortality is 8.5 per 1,000 live birth, which is really high. And along with that, if you look at safe and adequate water supply and waste disposal are lacking in more than 12% of the American Indian household. So we are still like thinking about third world countries. They are right here in our own backyard. Now, if you go back to look at the challenges in terms of, looking at what are the challenges we can think about, in healthcare. So everybody knows IHS, Indian Health Services, which is a free HMO to Native Americans. However, it's second-class care. They normally, if I go back to my previous slide here, that how much we spend on Indian Health Services, which is really kind of $3,000 medical dollars we spend on actual IHS spending, compared to federal prison, which is $4,803. So look at our priorities. Every dollar IHS needs, they get only 55 cents. And then out of that 55 cents, half of it goes to bureaucracy. So look at those people on the ground who gets their care, don't have enough support in terms of covering their healthcare. So now, if you look at, why I'm saying it's a second-class care, the budget is so low. Every year they try different ways to get funding and whatnot, but it's not there. The other challenges are like the practices with IHS and other, because now many of the communities across the country are getting out of IHS and having their own kind of, federal qualified health centers. But it's this, guideline discordant practices. And you will see a lot of clinical inertia. And we have not addressed the cultural impact in healthcare. So if you look at simple thing here, you have to take, this is, I have grown through my 35 years working with Native Americans, is that, they are really kind of, looking at the way where, you get clinical inertia, which is like you have to take medication, check your blood sugar. This is for typical diabetic. Cook healthy food, eat healthy food, make sure you are getting enough physical activity, be sure to balance all those things. And they will say, I have had enough. I would rather deal with the results of the disease. And that's what happens when you see patients in IHS. They are at the end stage of everything, every chronic condition you can think about. So I want to actually focus more about one of the diseases which I have spent a lot of more years in Native community, which is called chronic kidney disease. So chronic kidney disease, when we worked in this community called Zuni Pueblo in New Mexico, we found that it was really high. The kidney failure, rate of kidney failure in Zuni was about 17% compared to 1.2% in America. However, if you compare to other Native Americans, it was still 6 times more. And so, we were actually really looking at, how to address the issue about chronic kidney disease. If you look at chronic kidney disease in America, it's really high. It's more than 17%, However, kidney disease comes in stages, right? It's like CKD, chronic kidney disease. Stage 1, 2, or 3. And this, if you look at US population here, Zuni population is here. So they have early stages of CKD, stage 1, 2, and 3. So that allowed us to work with them because, kidney disease, only 5% move towards ESRD, meaning they fail the kidney, they get dialysis, or they can get transplant. However, early on, these stages, if you identify them, then you can intervene to look at, because, kidney disease is basically, 50% of diabetes related and 25% because of hypertension. So 2 factors you can address 2, and so you can intervene right there. However, if you look at monitoring of CKD in America, from 2001 to 2013, Native Americans didn't get monitored for many of the criteria, so they were not evaluated for creatinine level or lipid level or urine albumin levels, even though they have highest diabetes. So, this actually kind of tell you, thinking about it, that we are not working and kind of getting them into the clinics. So what we did, using this echo model of culturally cognate care, using community health workers, which are important part of the answer. They are the frontline agents of change. I mean, Indian Health Services has CHR. So CHR, CHW, promoteras, they are all same. They are lay interventionists. However, IHS use them to basically, shuffle patient, do paperwork and all. What we did, we actually really use them into making them as part of the clinical care team. So what are CHRs and how can they do care enhancement? The CHR services comes with improved access to healthcare, increased healthcare screening. That's what we needed also, right? Better understanding between community members and the health system. So because they are the link, they are from the community. That's the difference. Community health representative, meaning they represent the community. However, CHW can work anywhere in the country. Enhance communication between community members and health providers, increase use of healthcare services, improve adherence to health and recommendation for health recommendation and medication, and reduce need for emergency and special services. These are CHWs, which I have had actually kind of luck to work with, over all these years with so many of them. So what are the benefits of CHW approach? They are trusted by the population because they are from the community. They understand the sensitivity of certain health conditions because Native Americans are very private and they are with culture. So they believe in their cultural system. They still have medicine man, right? And so you have to make sure when you really think about helping Native Americans that, we get, I have a message, but I don't know what happened here. Familiar with the culture and language. I hope I'm not over the limit. Maybe I am over the limit. Let's see if I go. Okay, I think I'm going to skip some of the thing, because I'm told that I need to do only 25 minutes because I wanted to show you one of this study, which I'm really proud of, doing. This is a PCORI supported study of randomized clinical trial where we recruited 100 people, 50 for the home-based care, where the CHRs went to people's home every other week and really activated those patients. The primary outcome was patient activation, where you can see here in the result, they improved by 8.7 points. However, with that, the clinical picture also improved where they lost BMI, high sensitivity CRP came down, A1C came down. And this was icing on a cake, which is mental score improved by 5 points. So what we concluded from that PCORI study was that home-based CHR delivered intervention improves participants' activation in their own health and healthcare, and it may reduce risk factor for CKD in rural disadvantaged population. This was the model where it was delivered by CHR. We had patient preference as an innovation, point of care testing. We used to take A1C machine into their homes and they will do A1C every 3 months and will say, oh, you are still 10. We talked about how to reduce it. Can you do this? And telemedicine, where I always had my cell phone. So I can look at when the staff call or CHR calls and I talk to the patient. Text messaging, was other one interesting thing. We used to randomly send text messaging for motivational thing only. They don't have to respond. So this actually really help us to preserve their kidney function where they were instead of replacing it. So in summary, what I can tell you is that Native Americans, half of them are still uninsured of low-income AI, right? There are gaps in healthcare and rates of service utilization. More than 55% of American and Alaska Natives have income below 200% of federal poverty level, compared with 25% of the whites. Nonetheless, despite some pockets of good news, decades of well-documented challenges and underfunding still remain. To begin to put Native America on a path to health equity, adequate funding that supports evidence-based, outcome-based, and community-based approaches are really essential. Quantifiable goals need to be set to focus explicitly on chronic illness reduction, and associated measures need to be defined and closely monitored. A strong investment in public health, which is really needed. I mean, that's why I was a public health person there, and that's what I did. Additionally, access to specialty care, a greater pipeline of health professionals to serve in tribal communities, including much larger scholarship and loan repayment program, as well as technological investment in Zuni. We still don't have kind of, virtual thing. I mean, they all have cell phones, but internet is still lagging. So those are some of the stuff, which we need to focus on. So I'm sorry I went so fast on all this, but my goal was to kind of briefly touch base on the community I have worked for so many years, and they are to my heart. And I want to make sure you understand where I'm coming from. If any one of you interested in this program, we have created a toolkit for anybody to go work with Native communities or any rural area communities. It doesn't have to be Native Americans. And so this is the link for going on to it. And finally, I just wanted to, which I'm not going to talk about it. There are 3 slides. I have it. You will have access to those 2 slides. This actually really lists relationality, engagement, healthcare determination, systemic issue, barriers and access, and legacy of colonization for healthcare providers. I really want to thank you all for listening to me. I'm not available for question and answer because I have another appointment during that same time. But please, I have my email there. You can email me anytime, and my phone number is 505-321-9331. Thank you. Thank you all.
Welcome. I really want to thank our presenter for such a great presentation, and they can come on video. Just thank you and welcome to our Q&A session. We have about 19 minutes. Welcome Dr. Gansky, Charrington, Continuum, and Williams. And thank you, Dr. Shaw, for your great presentation. Really, the presentations were really, I think, thought-provoking, thorough, and I really appreciate the diverse perspective on research design and data collection, including the use of area level measures, practice facilitation and coaching, strategies, measuring the patient-clinician interactions, and using patient reflection, leveraging a learning health system and digital care engagement, and really the use of healthcare workers to promote a culturally congruent care. And so my first question for the panel is, what are the most promising advances or new methods to explore when conducting research on healthcare models for multiple chronic condition? I know you all touched on it, but what do you think? You want to highlight more kind of the methods that you talked about? What are the most promising advances or new methods? And kind of a follow-up, I thought it was great that you all talked about different methods or strategies or components of healthcare models. But do you think the research methods are rigorous and robust to really combine practice facilitation with digital health, with the learning health system? Are we ready for those type of research studies that combine multiple components? And feel free to unmute yourself and chime in.
Okay, well, I'll jump in. Just to kick it off, maybe. I think
Thank
we
you.
are ready, beyond ready for trying multi-level and multi-component interventions. I think, and I really appreciated some of the other speakers touching also on the combination of different intervention modalities, high touch, high tech. Certainly for us, practice facilitation, I think combining that with peer coaching, I think we have opportunities to better integrate some of those components. And so I guess in answer to your original question, I think in terms of innovation and where we're going, I think the point that I brought up during the talk is this need for sort of better data. I think it was maybe Albert Wong yesterday who talked about data integration. And so I think that's one of the areas for innovation that we really need, is to figure out ways to draw these different data sources together and really integrate them for continued observation and measurement. I won't claim to have figured out how to do that, but I certainly want to partner with people who are good at it, because I think that's really where the field needs to go, is integrating these different data components in ways that enable us to use them more easily, to both look at our baseline measures and benchmark where we are, as well as how we can affect change over time.
I think another novel and innovative approach would be using more adaptive designs in clinical trials. So currently we have another PCORI funded study that is looking at that for other complex health conditions. And so that's a really great flexible model for really being able to look at multi-component interventions, but then also adapt your randomization to modify kind of the trial's chorus in terms of making sure patients are getting allocated more often to the best performing arm or treatment group. So that's just another innovation I didn't cover in my slides today, but I think that's an important one to consider. I think they are difficult, of course, to design and make sure you have the right sample for it. But if we are looking kind of at a system level, a payer or a provider system, they have the ability to be able to run those kind of designs. So I think the more we can make the case for those, the better as well.
I think I'd like to echo that. Having sort of a flexible design, my focus is on encounter research. So what can we do on a patient level? And I think especially with all the developments in AI and automated analysis, I wonder whether we could have each individual patient choose their own outcomes that they want to improve in care. And then eventually groups may be big enough to say something on the group level, but also to ensure that each patient has improved outcomes on the outcomes that actually matter for that particular person, and not just for science or group level analysis.
I'll also chime in on that, and a little more specifically in terms of the new designs and the ability to adapt and change, particularly if something's not working, to, let's say, reduce blood pressure or control diabetes, would be the so-called SMART designs, which have benefits over adaptive randomization, in that they're easier to analyze and they can tailor a little bit better. So I think that's another area that could be explored further.
That's great, because that was one of my questions, kind of getting at, how do we create, implement, or evaluate these healthcare models that really take into account the individual person's wants or needs or outcome, kind of this precision health that was mentioned yesterday. So it's good to hear that mention. So kind of getting back to the data integration question that you brought up, Dr. Charrington, my question for Dr. Gansky, how can the neighborhood, like community context, be integrated, that area level data, especially the census tract, be integrated in healthcare delivery and healthcare delivery research to better understand or address the needs of persons with multiple chronic conditions?
Yeah, so one way is to integrate it into electronic health record systems. I know that a lot of primary care clinicians are already bombarded with a whole slew of conditions to screen for or items to ask about, but there's still the opportunity to ask about social determinants of health based on place and where people live. And there are some really fantastic examples of how that has benefited, and not just benefited the one individual who's there in the office, but an entire group of people who live in that community. So for example, there's a marquee study from Cincinnati Children's Hospital where they screen for about the living conditions of a child, including water and clean water and lead in the water, as well as clean air and lack of mold in where they're living. And what they've done is then they connect, when they have a positive screen, they connect to a medico-legal team that then goes to that landlord and sues them if need be to get them to abate the problems. And so everybody in the entire building actually benefits from this one sentinel event. And so I think that there's an opportunity to have that kind of multiplier and think creatively, how can we upstream impact communities in that way?
No, that's great. And I know, and I can't remember which presentation, but someone brought up that, for certain community, there aren't resources. And so what can be done to still meet the needs of the patient who might be dealing, like we said, inadequate housing, and managing the chronic condition is not going to be at the forefront. What are innovative methods or research designed to perhaps address that? And maybe you all can speak more on, how would you use this data outside the clinic wall to integrate in the healthcare system, if it's appropriate? I would love all your thoughts.
So I think I'm the one who mentioned the resources, especially kind of given the context where we are. A lot of times there aren't community resources. And we heard yesterday in our breakout session, actually, from someone who was in our group talking about how there wasn't funding available for a particular intervention that was determined to be successful or effective during a research study. And they went to local businesses to say, hey, this clinic is serving your employees, basically. Do you want to contribute to a fund, a charitable fund, to help provide this position? In my head, I'm hearing community health worker, but it might not have been for community health workers. But regardless of what it was, I thought, a very innovative solution to try to create a community resource from partnering with the people who stand to benefit the most. I know we've done that locally, tried to think about, okay, and I'm in Alabama, we haven't expanded Medicaid. So we are grappling with that, but we're trying to figure out how to support community health worker interventions. And so we partnered with a local hospital and health system to try to say, hey, maybe if we partner with you guys, will you pay for us to provide support to people who keep coming to your emergency department for their diabetes care, when really they could be going elsewhere if they had the support to do that. And so I think trying to think creatively outside the box about who's paying for this anyway, and how can we leverage some of those resources to help provide funding for what we need to address health equity. I think that other opportunities are lean into the digital space. How can we take telehealth, for example, if there aren't particular clinical opportunities in rural areas? I think increasingly people are using some of those technologies and digital technologies to try to get around lack of resources. So I think there's several creative strategies. I think I would just go back to sort of some of the earlier presentations around engaging people who are both payers and users on the very front end to find out what data you need to then take to said stakeholders to try to advocate for those resources. So it just really starts from the beginning of these intervention studies where we really try to make sure that we're getting the data that we need to make the argument later on.
That's great. Anyone else want to chime in?
I did notice a question in the chat.
Yes, I was
That
going to ask
actually
that
also
next.
kind of relates to the same topic. So, so I'll take a stab at framing some of the challenges, I think, related to collection of CDEs. And then I would hand it off to Stuart, who I know has thought a lot about this as well, and maybe with a question from me to him. So we have one of the P50s, and so we are also collecting common data elements as part of that through all three of our R01s and now some of our supplemental studies. And so there were a lot of challenges and a lot of discussions, very rich discussions, and I think I would commend our coordinating center and NIMHD from being very open to those discussions, I felt like, in a lot of ways. But there are challenges related to collecting some of these common data elements. And so we want to be very community partnered in our efforts, which means we need to go to our partners and say, look, this is the data we're collecting. And so some of the topics related, especially to social determinants, can be very sensitive issues. And so one of the things we ran into from our PIs was, hey, if we're asking about this in a community, let's say something around intimate partner violence or something else, where you may need a resource to address the answer to the question you just asked, but maybe there's not a resource available in the community. What's your responsibility as an investigator and to follow up on those kinds of questions? And also, what about when your community says, well, we're doing a gardening intervention with fruits and vegetables, and why are you asking those questions? And so I think there was a good amount of pushback, not just from investigators, but I felt like investigators on behalf of their community partners oftentimes. And so one of the strategies I think we could use to help promote, because I understand in some ways, the effort behind collecting the CDEs, but I wonder if we could make a more concrete example or argument for our community partners as to why and how this data will be used in very accessible ways, like a concrete example of what we're going to do with this data that would be of value to the communities that we're trying to serve, so that they could say, okay, well, yeah, that makes sense. Let's get behind that. And so, Stuart, I wondered in y'all's conversations with, in particular, the Community Advisory Board, if concrete examples had come up or ideas had come up from community that we could then take back to some of our partners to say, hey, here's some of the examples, and sort of try to build momentum for the collection of these. Because I get the importance, but sometimes it's a stretch for folks.
Yeah, thank you. So that frames the issue. I'd like to add a little extra framing before I delve into some more of the details of how, what specifics came up from the community. And the first is to take a step back and think about, early in public health training, thinking about what's ethical in terms of screening. It's not ethical to screen for something if you don't have a treatment for it. And in a similar way for the social determinants of health, PIs, center directors were saying, it's not ethical for us to ask these questions because we have nothing to give them. And so we're just identifying a problem amongst people who have a lot of challenges already, who are in low-resourced communities, perhaps high-risk communities for health conditions, these health conditions. So that was one of the components, and we heard it for sure. And as I wrote in the chat, the timing of how we went about doing this was not ideal, and we are working now to sort of think about the future. And I mentioned in terms of the optional items, and think about the future of going to the community, what do you want to know about, and working through what could we as a collective consortium of 11 centers and 40 some projects, R01 level projects, what do we have the opportunity to do synergistically that an individual R01 can't do, and framing it that way and trying to figure out what pieces of information we need in order to put the to answer the question or solve the puzzle of how do we reduce multiple chronic conditions and disparities related to them. So that's one thing that I would suggest, is to start early, work with the communities. The communities have been working with their centers and their project PIs, but they didn't know us at the coordinating center. We were, just new people who were new to them. So we had to work, build that trust, just like the investigators and center directors did. The items that were very much of interest to the communities were related to resources in particular, and environmental exposures, chemical exposures, things like food resources, physical activity resources, safety in the community, ability to get physical exercise and feel safe in your community. And so those were amongst the things that popped out immediately. But then we've also had some additional discussions, and so we're hoping that there will be more that will come out of those discussions, and there will be richer discussions and variables or measures that haven't yet been part of the conversation.
That's great. And I do want to pivot one more question before we move to our next session for Dr. Kuhneman and Williams, talking about the digital health, decision support. How do we make sure that those technology is available for those most at need for resources and support? Can you talk about that in the 1 minute we have left?
Well, I think there are a few downsides of decision supports, at least. First of all, they are often disease and context specific. So this is very complicated for people living with multiple chronic conditions. And we actually see that either decision support tools are developed but not evaluated in clinical trials, or they are evaluated in clinical trials, but then the funding ends and it's really difficult to keep these decision support tools up to date of the latest evidence. So I think that's a challenge, but also what I mentioned in my presentation, a recent study also showed that even if these decision tools are available and they are promoted through EPIC, we also see that there's a lot of clinician variation when clinicians offer them to patients or decide not to use or to offer them. So there's a lot to win even on that patient level. Even if you have access, you may not get it.
Great. Well, I could keep talking. This has been a great discussion. Please, there's some more questions in the chat. Comment. This has been a great discussion. I just really want to thank our speakers for presenting and engaging in the discussion. But now it's time to move on to the next session with moderators Dr. Carolina Solis-Sanabria and Radha Dagar. Thank you.
Hello, everyone. We are now moving on to session 4, entitled Research Methods to Advance Multi-Level and Intersectional Research on Multiple Chronic Conditions. My name is Carolina Solis-Sanabria, and I'm a program official of the Division of Clinical and Health Services Research here at NIMHD. I will be moderating this session along with Dr. Radha Dagar, who is also in the same division. We will first have Dr. Mark Johnson from Howard and Dr. Carrie Gross from Yale speak, followed by a 10-minute Q&A, and then Dr. Radha Dagar will moderate the session and Q&A with Dr. Matthew Maciejewski from Duke and Dr. K. Allen Greiner from the University of Kansas. Of note, this is a slight modification from the agenda. However, you will still have an hour of lunch. It's just that the Q&A will be split in 2 sessions. As we've been doing, please type in your questions in the Q&A box. Speakers can continue to answer questions that are relevant to their talk in the Q&A box before the Q&A session starts. Thank you so much. And now we'll have Dr. Mark Johnson speak.
Good morning. This is Dr. Mark Johnson from Howard University. My talk today is Complexity in Research in Patients with Multiple Chronic Diseases, a Team Approach. I am indebted to, if you will, the contributions from Dr. Zahuni, who said, when he was putting together CT essays that many problems of the 21st century cannot be solved by one discipline alone. I think this is a good entree to our topic today. In the early part of the 20th century, the major etiology of mortality was infectious disease. After the advent of better sanitation and antibiotics, infectious disease became less of a problem related to morbidity and mortality, and we started to have an increase in chronic diseases. Another aspect of this, of course, is the fact that we have more chronic diseases as our population ages. So that model gives you one cause and one effect. You have one germ, bacteria, virus, and that gives you X disease. There are epidemiologic principles that we go through to try to establish that causation. And once you do, it's pretty easy to understand. However, today, our major problem is chronic diseases. More than half of adults in the country today have at least one chronic disease, and more than a quarter of people have multiple chronic diseases. So if we are to understand disease processes within the holistic view of the patient, we must be able to consider other concomitant diseases that are going on. Research in a population that has multiple chronic diseases requires a different approach, and I'm going to talk about that a little bit now. For example, if you have an obese patient with schizophrenia who is started on a new medication, and all of his symptoms goes away, but during that period that those symptoms are going away on the new medication, he gains 50 pounds and he gets the diabetes. Is that patient improved? Or are there other ways that we should be assessing the outcome of the research? If I'm a psychiatrist and all I'm interested in is psychiatric symptomatology, and I can make that symptomatology go away with this medication, I may be satisfied. But if the measurement of outcomes includes things such as quality of life, then the patient may have preferred to be psychotic than to be more obese and diabetic. So this is just an example of the interactions that can go on between two chronic diseases. So when we do research related to multiple chronic diseases, there are a variety of extra steps that we have to take. We must prioritize the diseases. Usually there's going to be one disease in question that is most important. But if there are other diseases that are also present, we have to make sure that we are not making those disease processes worse while we are making the disease process of initial interest better. We have to consider what is the psychological burden of the disease. This can be crucial because if the patient perceives change that is not positive, then that can also impact on the patient's quality of life. With all situations, it's incumbent upon us to take into consideration social determinants of health. And these are variables that impact outcomes, both for the primary disease in question as well as the other diseases that are coexistent. And then finally, we have to consider costs. So that's going to be costs of care, but also cost in what does it take for the patient to get the therapies, as far as time off from work, transportation issues, care of children issues. All of these should be considered while we are taking care of patients with multiple chronic diseases. So I like to think that when we look at data from this research, we're not looking at a straight line from a cause to an effect. Rather, we are looking at what is on this slide, a D prime, which is a disease that we are most interested in, and then D1, 2, 3, and 4, which are the concomitant diseases that are present. All of the issues that we usually have methodologically in determining the course of the research have to be considered here sometimes multiple times. So, how are we measuring each? What are the ultimate primary outcomes that we want to assess? What are the secondary outcomes that we want to assess? And so going across the top, you see I1, I2, I3, and then you see social determinants of health 1, 2, 3, and 4. And so you see how the outcomes or variables that we consider going across the top are measured potentially as a response to each of the diseases besides D prime. So this is a matrix type model that can be complicated statistically, but sometimes is absolutely necessary if we're going to come out with the outcomes that we really want. Another model is to combine several chronic diseases. An example of this is the metabolic syndrome, where we are looking at blood pressure, we're looking at hyperglycemia, high lipids, and obesity, all in one model. And the American Heart Association has recently added another consideration onto this by calling it the heart kidney disease, because all of these affect the kidney. Here, where we find that things like high blood pressure and obesity and hyperglycemia and high lipids all run together, allow us to look at this as an entity in and of itself. And in that all of these are not direct causes of diseases, and rather intermediary causes of diseases, such as heart disease or stroke or diabetes, then we can sometimes choose to look at this as one entity. And so there are opportunities for us to do that. What's really important, and is one of the key parameters that we're supposed to be discussing in this panel, is the necessity, the requirement of having a multidisciplinary team. One of the reasons that I came to Howard is because Howard, as a university, not only has a medical school, but there's a dental school, nursing school, a school for pharmacy, as well as engineering and the humanities. And the ability to have all of these disciplines available in one place to collaborate on research is really phenomenal, and is one of the special things about Howard and universities that are similar to Howard. So what are the components of the team that you try to put together? The team has to have a leader, most often this leader is going to be the person who has the vision and or the initial idea for the research project. If that leader is not a content expert, you may want to have content experts on the team also. And if this is a process, or if you're going to be studying diseases that are in different areas, you may need to have multiple content experts on your team. I am convinced that many of the problems that we need to solve in research today require work with people in health communications or linguistics. There has to be a science to behavioral change. There has to be a science to understanding the best way to listen to patients, to respond to patients, and to give patients advice so that we increase the adherence that they have to the scientific recommendations that we can give them. We need health technology, and from the form of wearables to having computerized interventions that go as far as AI and machine learning. We need to have methodologists that can help us put together the type of research designs that will answer the questions that we are trying to answer. And along with that are the biostatisticians who can give us the results of our hypothesis testing. We need psychologists and other behavioral scientists, because every aspect of healthcare has a behavioral side, whether we recognize it or not. And the burden of chronic disease on an individual is partially affected by that person's resilience or coping skills, or whatever coping skills we can give that patient. And so we need to have input from behavioral folks. And last but certainly not least is nutrition. We are now at a stage in medical care where we are recognizing that food is medicine, and we have to be able to make sure that people get what they need in order to optimize their recovery. The final member of the team that I would give is the community. Too often we have operated from the stance of the ivory tower, and we have developed interventions for the community, either individually or collectively, without asking them what do they want or what are their priorities. And so getting our community input is very important if we want to increase the legitimacy of the research that we are doing. So simultaneously, if we do that well, we empower the community. We empower the community to ask questions. We empower the community to be self-regulatory, if you will, so that sources of motivation for positive behavioral change comes from within the community, and that's something that we would like to see. We have to have bidirectional communication with the community so that they understand that we are listening to them just as much as we expect them to listen to us. And I have down there as a final bullet, even big data research can learn from this cooperation, because we need to know, by talking to the community, what are the most important questions to ask. So, some of the areas that we see participatory research going on is with is going in the community, getting them to participate, not at the end of the design of the project, but at the beginning of the design of the project. Primary care research is important because primary care clinicians are very used to seeing patients at the point of first care. And when they come in and they have multiple problems, those problems are prioritized and are understood from the point of view of the patient. And finally, I think it's important that we mention geriatrics. Because geriatric people are older, then they have more time to get chronic disease. And so whenever we are looking at outcome of any single entity in the geriatric population, we must also be ready to respond to the other diseases that are present. So I enjoyed putting together teams. I think that's the way to go. And I'd be interested to hear any responses to this presentation. Thank you.
Greetings. I'm Carrie Gross, Professor of Medicine and Public Health at Yale School of Medicine. And I just wanted to say how much I appreciate the invitation to participate in this day. Multimorbidity is a topic that has been of great interest to me. You might say it's one that is near and dear to my heart, and I'm excited to be part of the discussion. So without further ado, let me share my screen here. First, some disclosures. The outline for my talk will be as such. First, I wanted to talk about comorbidity and cancer. This is the clinical conundrum that has been a focus of my research for quite some time. Then talk about a different direction, a case study where I will speak about our ongoing work involving incarceration and cancer. And finally, some thoughts on building multidisciplinary teams. So first, comorbidity in cancer. Here's some work that our colleagues did some time ago involving colorectal cancer and looking at older persons and estimating the population attributable risk. And what we found was that this is only among people with colorectal cancer. Congestive heart failure, or CHF at the bottom, was actually the cause of roughly 9% of deaths in our sample. COPD, or emphysema, was the cause of roughly 5 or 6%, diabetes 4%, etc. Take-home point here is that even among patients, older patients who have a serious illness such as cancer, we have to be thinking about multimorbidity, or in this case, comorbidity. We found that these chronic conditions had a profound effect on the receipt of recommended adjuvant cancer therapy. For instance, people with heart failure were less than half as likely to receive the recommended chemotherapy as patients without heart failure. Similarly, diabetes and COPD were also associated with a lower likelihood of treatment. Although we found the effectiveness of treatment is not necessarily mitigated by these conditions. In separate work, we looked at life expectancy as a function of multimorbidity. This is among patients with early stage colorectal cancer. And what we found was that here on the y-axis is life expectancy. What we found was that among patients with 3 or more conditions, pretty much across all age groups, this is age at diagnosis along the x-axis, the life expectancy was only around 5 to 8 years. Similarly here for men. Whereas people with 0 conditions, there was a strong linear relationship between age and life expectancy after stage 1 diagnosis. This has profound implications for how we consider cancer screening programs, because if the life expectancy is very short after early stage of diagnosis, screening is much less likely to have been helpful in the first place. Let's raise the larger issue. And again, this is going back to some of the earlier ways I was thinking about this, placing chronic conditions in the center of this initial model of multimorbidity, thinking how they affect symptoms, how they relate to polypharmacy, physiologic dysregulation, and how all of these things may have an effect on cancer physiology, impact on cancer care, as I mentioned, the effectiveness of screening or the receipt of treatment, and all of these together may impact patient outcomes. But now to make this a little more realistic, a little more clinically salient, I wanted to think about how we can basically think outside the box, or rather think in a more three-dimensional box here, to get outside of just focusing on the clinical determinants. And that's one of the main areas that I wanted to discuss today, was thinking through when we're pulling together these multidisciplinary teams, how can we consider things such as social determinants, patients' environments, which we'll talk about shortly, access to high quality care, other sociodemographics, social support, also behavioral determinants, diet, physical activity, etc. All of these have a profound impact on chronic conditions, incidence, severity, and how they interact with one another to affect patient outcomes. And this brings us to a partnership that I wanted to highlight. So I lead Yale's Cancer Outcomes Center, which is called the Copper Center. And it's been my great privilege to work with Dr. Emily Wang at the SACE Center at Yale, which focuses on incarceration and health. And Emily and our offices have been next door to each other for almost 10 years. And it was only after a great deal of conversations about shared interest in improving cancer outcomes, or in her case, improving outcomes for patients who are incarcerated, that we end up forging this partnership to look at cancer among patients who are currently or formerly incarcerated. Now, this has a very strong motivation in terms of health equity and mass incarceration. I'm sure all of the viewers today know also has its roots in systemic racism. So 1 in 10 men have amongst all men, the lifetime likelihood of imprisonment is roughly 1 in 10. For white men, it's 1 in 20. Black men, it's only 1 in 5. And Latinx men, it's 1 in 8. So when we want to think about equity, it's critical that we think about things such as mass incarceration, how that affects patients, how that affects treatment of multiple chronic conditions and outcomes. Incarceration can not only affect access to care, but also can have a profound impact on disease management, on timeliness of care, whether it's for screening or for treatment. So our partnership focused on 3 distinct groups: people who were never incarcerated, those who are currently incarcerated, and based upon earlier work by Dr. Wang's team and others, the people who are immediately post-release. That's been found to be a time period when there is a particularly high risk of adverse health outcomes. So across these 3 clinically distinct groups with regard to their time period and with regard to their context, we looked at incidence and diagnosis of cancer, cancer care, and cancer survival. So I'll briefly talk about each of these. Our study team included faculty members from across the Cancer Center, other aspects of the Yale Schools of Medicine and Public Health, but importantly, individuals who are part of the Connecticut Departments of Corrections and the Connecticut Department of Public Health. So really moving outside of Yale, outside of New Haven, to include key institutional partners. In addition to that, we created an advisory group that included people with personal and family history of incarceration to ensure that we were maintaining and elevating patient voice in our partnerships. So the first study we looked at, led by Janarius Amina Wang, explored cancer incidence and how that was related to incarceration status. And this involved a tumor registry linkage with the state of Connecticut that was linked to the Connecticut Department of Corrections, and also that was their master file for location of of individuals, as well as the movement file, which tracked people's incarceration and release, or sometimes recidivism status. So this linkage, it seems very straightforward, but it involved really arose from substantial long-standing partnerships between Dr. Wang's group and the State Department of Corrections. Our group has worked with the State Tumor Registry before, and it is really this long-standing relationships and basically a sense of trust between the different partners that help to facilitate this work. What we found was that in the general Connecticut population, the incidence was roughly 700 per 100,000 people. For the people who were incarcerated, that's the Department of Corrections bar in the middle, there was a much lower incidence or detection rate of cancer. And then in the post-incarceration group, within 12 months after release, a much higher cancer detection rate. This raised the question of whether perhaps there may be some cases of cancer that were being missed while incarcerated and then kind of having a rebound effect afterwards. So then Dr. Ilana Richmond took this question and ran with it, looking at stage of diagnosis among patients who are incarcerated. So here, the y-axis is the percent of patients who have early stage disease. So here, the incarcerated group, roughly 46% of patients who are diagnosed with cancer had it diagnosed at an early stage. In the early release population, over 50% early stage. In the full state of Connecticut, about 65%. So a really strong relation between incarceration history and being diagnosed at an early stage. However, when we share these data with our partners at the Department of Corrections, they raised a really important question, basically whether it's really fair or valid to compare people who are incarcerated or recently released to the full Connecticut population. And they said, well, maybe it would be more appropriate to compare to patients who have Medicaid, because most people who are released, when they do get insurance, it's more common to be Medicaid insured. So in response to that, we added this whole new comparison group, and that was just focusing on the Medicaid population in the state of Connecticut, which is, as you would expect, is lower early stage diagnosis than the full state, but somewhat closer to the recently released. Incarcerated was still a little bit less likely to be early stage at diagnosis. However, when we looked at specifically screen detectable cancers, it was a different story. Here, the incarcerated population was basically the same as the released and Medicaid population. All of them were trailing the full state of Connecticut. Take-home point here is that there's opportunity for improvement across all of these groups, both the Medicaid and also the incarcerated and recently released. Finally, we looked at incarceration and cancer mortality, led by Damilola Oladaru, where we found, here the y-axis is survival, where we found that people who were never incarcerated had a much higher survival rate for cancer than patients who were either incarcerated or whose cancer is diagnosed immediately post-release. Just a few thoughts on our partnership. This is one of the main facilities in the Connecticut State Department of Corrections. And as a next step arising from this partnership, our partners in the Department of Corrections highlighted that they are working to improve their colorectal cancer screening rates. So we turned to them and asked, when we're thinking about a renewal for our grant, what should the topic be? And they immediately said, can we think of something together that would creatively address colorectal cancer screening? So working with our partners, we're working on a plan to improve or iterate the approach to colorectal cancer screening, to implement this multi-level colorectal screening intervention, study its impact, and then iteratively improve the intervention. And just a quick highlight that the real important thing here is not only to center the institutional partners, but to center the patients and the people and the family members who are affected by these conditions and by these situations. So just a couple thoughts on building multidisciplinary teams. I mentioned that Dr. Wang's office was right next to mine, and it took us a while to finally find a way to work together. So getting out of silos for us was a really helpful, essential actually, approach to moving ahead and identifying partners that are outside of our traditional workspace and outside of our traditional work environment. Secondly, having a shared mission. All of the partners in our group who have very diverse interests and life experiences and in some degrees day jobs, we really all shared strongly a common interest in improving the health and health outcomes of people who have been incarcerated. So a shared mission. Finally, this figure might be a little hard to follow, but the idea here is that it took a while for this to come together, for these disparate groups to eventually move from kind of free-floating folks into a nice tight-knitted team over here. And what I really want to emphasize with this figure is the patience and not rushing the partnerships and identifying people and getting to know them over time and getting to understand what would be helpful for them. And that really helped to drive the team and pull it together. And finally, equity in terms of sharing power, sharing responsibilities, sharing decision-making for us was a key component in building a multidisciplinary team. So really a grassroots approach. I see that I'm over time. I wanted to thank all of our collaborators, our community advisory board members, key team member, Jerry Smart, who is no longer with us, and also our funding agency, of course. So thank you, everyone, and I look forward to, here we go. Okay, I look forward to discuss.
Hello, everyone. Thank you so much to Dr. Johnson and Dr. Gross for these wonderful presentations. I invite you both to turn on your cameras. I see Dr. Gross already has his on for our Q&A time. I also invite people to ask any questions in the Q&A box. I appreciate Dr. Johnson's discussion on having a multidisciplinary team and community involvement, as well as Dr. Gross's discussion on the challenges experienced by incarcerated patients with cancer diagnoses. And so, first of all, I'd like to ask a question for both Dr. Johnson and Dr. Gross. Both of you described the importance of the team and having a multidisciplinary approach. And so my question for both of you is, how feasible and sustainable is it to create and maintain this quote unquote village? So a comprehensive healthcare team, which includes various healthcare professionals, caregivers, patients, for the management of multiple chronic conditions, and especially in underserved areas and prison populations, as you discussed, Dr. Gross. And what are some of the most successful strategies to do so?
Well, I would say that most important thing comes from shared vision. If you have a team and the team is committed to a certain disease process or a certain community or a certain disparity, putting together a vision as to how that team should move forward, and how the leader of the team can guide that process through making sure all the team members are taken care of, so that they can concentrate on doing their work rather than where their salary is coming from, is important. And it's almost like a family. If you get a good team working together, it's almost like a family who's working together toward a common cause.
Yeah, Dr. Johnson, I think that's a great way of putting it, because within academia, it's a strange world where the coin of the realm in some instances is kind of like publications. But as far as pulling a team together, getting a high-profile publication is not the goal for most people in the world, or particularly most people on an interprofessional team. So having a clear mission, of what we're trying to achieve and why it's important, and listening to to team members when they have suggestions about maybe a change of direction that'll get us closer to that goal. I think is so important.
Thank you so much to the both of you. Now I have a specific question for Dr. Johnson. You spent some time outlining the specific team members that are important. And so just a little bit more detail on that, the team members in terms of how could that team best be operationalized and sustained? I know you mentioned vision is really important, but just in terms of, working at low resource academic institutions, what thoughts do you have to best operationalize and sustain that team?
Well, again, I have to bring up the topic of leadership. One of the things that the team leader has to do is to understand what are the personal interests of each team member. Usually the leader is going to be senior, and the people on the team are going to want to rise within the system, and so they may need mentorship in certain areas. As some of the mentorship can be gotten within the team or within the university. Sometimes you have to reach outside to get mentorship. Being able to show them where to get resources so that they can do independent work. Showing them how to find collaborators in other institutions or in other departments. So whenever you have leadership in this type of situation, the leader is focused on getting the job done that you're currently funded for. But you also have to take into consideration the development of all the members of the team.
Well, that's a really great answer, focusing on the human capital. And I have a question now for Dr. Gross. Just more generally speaking, what do you see as some of the opportunities to move the field of multiple chronic conditions research forward?
Yeah, thanks. So in addition to, we've been speaking about the interprofessional teams, but also a couple of things. One, funding, which hopefully that's where this whole workshop today is heading toward. A recognition that the NIH is set up in these disease-specific silos. So, understandably, the way that institutes were originated was around a focus on specific diseases. So, I'm really excited to see this implication of this talk today. It's around hopefully inter-institute collaboration, really funding toward this challenge of multiple chronic conditions. In addition to that, and Dr. Johnson alluded to this in his talk earlier as well, thinking through what are the outcomes that are important to patients, or whether it's not simply looking at just mental health or simply looking at diabetes, for instance, but can we think through what are quality of life outcomes or patient-reported outcomes that are perhaps universally important across all conditions? Or even the idea, Victor Montori out at the Mayo Clinic has done a lot of work looking at treatment burden. So in addition to the burden imposed by a disease and its symptoms, but thinking through what are we asking patients to do as far as number of pills per day, number of visits to the doctor, number of injections, that sort of thing. So I think having a broader perspective on maybe disease agnostic outcomes, and also a broader perspective on the risks of treatment, or I don't know if you want to call it treatment burden a risk, but this thinking through like costs, time cost, emotional cost, as well as financial cost of treatment would be really, really helpful to help us again to step out of these disease-specific silos.
Well, thank you so much. I think we're at time. We may have maybe 30 seconds left. So really quickly, what are some of the key methods that you think are important in doing this kind of research? So, maybe your 5-second answer.
I'm really looking forward to use machine learning and deep learning to get more detail out of the matrix type designs that I alluded to earlier.
Great 5-second answer.
Oh, and I'll just add, in addition to this quantitative, I already used up my 5 seconds. I was going to say qualitative research also is really important to understand the patient experience.
Thank you so much. And with that, we've concluded the session with both Dr. Johnson and Dr. Gross, and we're moving on to lunch, and then we'll be back with Dr. Radha Dagar moderating the next half of the session. Thank you.
Thank you.
Bye.
Hello, everyone. We are now continuing the session entitled Research Methods to Advance Multi-Level and Intersectional Research on Multiple Chronic Conditions. My name is Radha Dagar, and I'm a program official in the Division of Clinical and Health Services Research at NIMHD, and I am moderating the second part of this session. We will first have Dr. Matt Maciejewski from Duke University, and then Dr. Alan Greiner from the University of Kansas, followed by a 10-minute Q&A. As we've been doing, please type your questions in the Q&A box. Speakers can continue to answer questions that are relevant to their talk in the Q&A box before the Q&A session starts. Dr. Maciejewski, please go ahead.
Hi, my name is Matt Maciejewski, a professor at Duke University and a senior research career scientist at the Durham VA Medical Center. And I'm going to present to you slides about it takes a village of scientists and patients to conduct impactful MCC research. Just want to note my disclosures of funding from these federal agencies and had prior MCC related work funded by ARC and ownership of Amgen stock. Outline for today's talk is that, as many of you probably know, MCC patients are tremendously heterogeneous. And so that heterogeneity is a fundamental challenge, I think, in developing research and building teams to conduct impactful MCC research. And we'll try to illustrate some of that through the engagement that I've done in prior MCC related research with team members and with patients, illustrating sort of principles of how we went about our work in a prior ARC-funded study on continuity of care and an NIA-funded study on deprescribing. It was an intervention study called Optimize. So as you may know, MCC patients are heterogeneous. That is, those with 2 or more conditions may have really different dyads of conditions and triads of conditions. And this table shows the prevalence of different dyads and triads based on 2010 data from Medicare fee-for-service. And so the fact that, you know, these are the most prevalent dyads that tend to relate to high cholesterol or high blood pressure, but when you get into the triads, you start having distinct combinations that are maybe different from one another, and that arthritis in the 5th most common triad with high cholesterol and ischemic heart disease may require involvement of different specialists than patients who have a triad of high cholesterol, high blood pressure, and ischemic heart disease, or high cholesterol, high blood pressure, and diabetes. That is the 1st or 2nd most prevalent triads. And so the underlying heterogeneity in the chronic conditions that MCC patients have suggests that it may not be possible to take a one-size-fits-all approach to the universe of patients with multiple chronic conditions. And that is, you know, if you've seen one MCC patient, you've maybe seen one MCC patient. And that this variability in the chronic conditions underlying their multimorbidity doesn't even factor in the heterogeneity of social risks that patients may be facing, which overlays the heterogeneity of their underlying chronic conditions that we do maybe characterize well. And because there is heterogeneity in the conditions that these patients have, different specialists managing these patients and different specialists who you may invite to your research projects may prioritize different conditions or differ in what conditions they consider central and which they consider more secondary, because each specialist may be looking under the lamppost of their particular cluster of organ systems that they are focused on and pay less attention to other conditions that are, say, discordant from the ones they focus on. And a helpful way of thinking about the cluster of chronic conditions that MCC patients may have is the framework of concordant, discordant, and dominant conditions that John Pate and Eve Kerr outline in a nice paper in 2006 in Diabetes Care that you may find useful for thinking about this in your own work. The work I've focused on has been largely around patients with diabetes, hypertension, and hyperlipidemia, which are all fairly concordant conditions. But in another study, when we tried to think about mental health conditions of depression or schizophrenia, those are very discordant conditions because they are managed by different specialists and require different medications and different therapeutic approaches than these cardiometabolic conditions that have been the focus of most of my work. And the number of different specialists involved in the care of MCC patients is illustrated in this figure from a very nice paper in 2007 in the New England Journal of Medicine by Pham and colleagues, illustrating that the number of providers managing a patient increases dramatically as you go from patients with 0 to 2 conditions on the left up to 7 or more conditions on the far right, driven mostly by proliferation of specialists as you get into 5 or 6 conditions or 7 or more conditions. And so that matters in that there's a lot of different specialists involved in the management of MCC patients, particularly those with lots of conditions, which has implications for the types of providers you might want to bring into your research teams. And the work that I've done in continuity care or continuity of medication management, has sort of unearthed that, as you may know, many MCC patients take many medications, and polypharmacy is very common among MCC patients. But and those medications are sometimes managed by very different providers who may not be working closely together to characterize the full medication regimen of a patient. And it may be that patients are stopping or changing medications because one prescriber is making some decisions that the other providers and prescribers don't know about, which can put them at risk for drug-drug interactions or drug-disease interactions. And without some comprehensive perspective by a primary care provider or through medication therapy management or some other comprehensive view of the full medication regimen, all these different cooks in an MCC patient's kitchen, as it were, may be working in very uncoordinated ways that definitely fragments care. There may be fragmented information exchange among these different providers. And it may be the patient who's the only one, and maybe their caregiver who's aware of all these different moving pieces. And so back in 2010, we got funding from ARC to try to understand how frequently, sort of building off of this Pham article, how common was it that patients were having multiple prescribers within the subset of providers from that prior slide. And we characterized that in a VA cohort, and then in subsequent work are ones that we got in Medicare and Medicaid cohorts. And we also wanted to understand if having multiple prescribers was associated with a range of patient outcomes, including medication adherence, disease control, healthcare utilization. And there may be good reasons to have multiple prescribers because you have multiple experts with very different domain expertise involved in the management of patient care, but you may have lots of trade-offs or downsides of that, including the care fragmentation and informational fragmentation that I mentioned. And so because we were doing research on patients with multiple chronic conditions, we involved a range of people with varying perspectives on our research team, including primary care providers, family medicine providers, a couple pharmacists, myself, a health economist, and a social psychologist. And together we were able to take a pretty comprehensive view at this, and you can find the published work in PubMed if you look for it. And that work in thinking about care coordination of patients with multiple chronic conditions spurred a recognition that we had very different perspectives on how we approached work and how we approached thinking about MCC patients and care management. And so something I did with colleagues at Durham VA and Duke was to develop a conceptual model to try to understand what was out there about characterizing patient complexity as a larger frame for thinking about MCC. And so after reviewing the literature of conceptual models related to patient complexity and multiple chronic conditions, we developed our own model shown here, which the process of developing this gave us a sort of unified frame for thinking about work we might do going forward. And so in working with geriatricians, primary care providers, statisticians, and health services researchers, we came up with this model, and it gave us a floor or a common way of approaching work together jointly. And it helped us also identify what measures matter in MCC research that we wanted to do, because there's a whole bunch that might be not available in administrative claims data and EHR data that we routinely use. Conceptual models can be really helpful because I think MCC and this related social risks are kind of an elephant we're each holding one part of, and having a conceptual model to sort of ground us to say, I focus on this part of the model, and that's the types of concepts I think about. Whereas I, as a health economist, not seeing patients, think about other concepts in a model, can help us get on the same page effectively and understand each other's perspectives and how to harmonize our perspectives to implement meaningful research. It can also help us achieve consensus when we're developing studies and thinking about inclusion criteria, exclusion criteria, the target conditions and targets for intervention, the outcomes that we want to focus on, unobserved confounding, and ultimately interpretation. So the next thing I'm going to talk about is how we engage patients in another MCC related research that I've been doing based on an NIA funded study of deprescribing. And so, but before turning to that, let me just mention, we got patient perspective in our prior care continuity work by using VA claims data on a large Durham cohort. And then a subset of those received a survey, and a subset of those we approached to do focus groups to understand the patient perspective in managing the information challenges of having multiple prescribers and the trade-offs of having multiple prescribers. And so this was our approach of trying to have a multiple perspectives of patient experience through claims, through a survey, and through focus groups. And the papers built off of that work is shown in the slide. And then in our more recent NIA funded work around deprescribing, we were trying to figure out how to introduce deprescribing to patients who were on many medications, having polypharmacy, and needed to potentially stop something without adverse effects. And this is such a new area that we needed to engage patients to get patient perspective on how to do such a new novel kind of thing. Standard of care doesn't really routinely screen patients for potential deprescribing. And so we wanted to engage patients to figure out how we could introduce this topic to patients, how we could talk through discontinuation, and how we might do so in a way that isn't upsetting to them. And a key challenge was when to deliver education materials to patients and how to do so. And so deprescribing, if you're not familiar, has several general goals for patients who have extreme polypharmacy: to reduce their medication burden and minimize the harms of polypharmacy, to reduce the risk of falls, to preserve cognitive function, and ultimately to reduce risk of hospitalization or death. And so the Optimize trial was funded by NIA to initiate deprescribing conversations in primary care with specific patients meeting these criteria. The primary outcomes were to see if we could reduce the number of long-term medications and reduce the number of potentially inappropriate medications, or PIMs. And we did this through giving patients and caregivers deprescribing materials and kind of information to providers about how to initiate such conversations. To develop this trial and the intervention, we had a team of 2 geriatricians, a family physician, a general surgeon, a pharmacist, and 2 health services researchers, including myself. And the Bayless paper is the site for the final results. We engaged patients before doing the trial to understand their perspective on medication discontinuation and how we might go about introducing themes or messages in our deprescribing materials. These qualitative interviews had several important findings. They argued that we should earn trust with patients before introducing deprescribing. We should frame it as a routine and positive thing that's aligned with goals of dementia care, because that was inclusion criteria. And we need to respect caregivers' expertise, give them educational materials directly, and engage pharmacists to support this work, and have close follow-up to make sure things are going well. In the trial, we mailed materials 2 weeks before the primary care visit, hoping it would be used. And then in a delayed control arm, shared materials at the start of an office visit, because in trying to think about maybe having patient staff do it, which was our alternative approach, had a number of problems with it, and it ended up not being effective. So at the conclusion of this trial, we still don't have a good sense yet of the optimal timing and mode of these materials. So this is a really important area that is still emerging and requires provider and patient engagement. So in conclusion, improving care for MCC patients is complicated by their complexity and diversity of conditions. Conceptual models can help teams work together to get on the same page and approach their work. Close engagement with these teams, patients, and caregivers at all stages of research, not just at the end, is critical for development of effective and scalable interventions. And here are some questions to consider when we're together live. Thank you very much.
Hello, this is Alan Greiner at the University of Kansas Medical Center in Kansas City, and I'm here to present to you today about rural health research and multiple chronic conditions, and talk specifically about some work we've done out here and address whether the COVID-19 pandemic or whether a focus on rural primary care can help our agenda in terms of researching as well as improving outcomes for multiple chronic diseases. So I have no disclosures today, so we'll get right into our objectives. My primary objective is to talk about these projects we've done, specifically get into details about how we put our teams of researchers together and teams of community partners so that we could address issues that might otherwise have been neglected and maybe have been with prior biomedical research. I'm going to talk about some models, primarily the socio-ecological model that we used for our work. I'm going to talk a bit about how a multi-level approach is crucial to this work. And then I'm going to talk in some detail about primary care and what we see in rural communities. So what we'll get into with our questions here are whether social determinants of health are as accounted for as they need to be in biomedical research. What can we do to improve that? How can we improve getting primary care providers more involved in research as well as community members? And can that also improve our ability to do work on multiple chronic conditions? So we're going to jump right in and start talking about the COVID-19 pandemic. Many of you probably are involved with this in different ways. We all saw devastating and early impact on communities that have historically suffered health inequities. Those were driven by occupational vulnerabilities as well as social determinants of health needs that often were drivers of transmission. We recognized early on, many of us in our work, the need for direct community input to guide the public health response, as well as to drive the research response, both in behavioral realms, public health realms, and in things like vaccine development and treatment development work. All those were crucial. So let's talk a little bit about what's been written about this. Just a couple months ago, a great article came out really showing the power that was harnessed for some of the work that happened and the crucial nature of social determinants of health in this work. That led to some things like the RADx Up program out of NIMHD. We had a grant here to do work in 10 counties, and it was really driven by something we developed in one of our urban counties here. I serve as a local public health officer, and we developed a model where community input was really driving our response. We had something called local health equity action teams, or LHEATs, that we put together. And we wanted to take that model to multiple counties and see if working on addressing things that those community members brought to the table could help us have a better impact on the COVID testing that was going on, primarily in Radix Up. That's what we were addressing. But again, a lot of our focus was upstream work to try and get into the communities that historically were having worse outcomes. We had 6 rural counties and 4 urban counties that we worked with. In those counties, there were different partners. So some of them, the local health departments were the primary partners. Others, it was a coalition, and in a couple, it was federally qualified health centers. We don't have a ton of federally qualified health centers in our counties out here, especially the rural ones. So in many cases, we are also trying to get connected to primary care providers in our work as much as we could. To put together our teams, our research team was really led by primary care providers too. We had about 5 on our research team. 2 of us were co-PIs, myself as a family physician and a colleague at Ellerbeck, who's a general internist. We also had a community member, co-principal investigator, and then about 15 other folks on the research team, including social psychologists, public health professionals, as well as social workers, and community health workers that were all part of that team. And then in the LHEATs, the community teams, they were as diverse as we could get them as well. We wanted folks from multiple sectors across the communities engaged in the work. And the idea was to test different interventions in different communities that were very community driven, and see if we could influence testing rates as well as test positivity. And what we saw, if we look at this, and what we did is we were able to get enough data out of 9 to 10 counties to do this analysis. And then we had 21 matched control counties. What we found is that there really wasn't any change in the test positivity rate between the 9 counties and the 21 counties before the intervention. And then if you look at just the 21 control counties, they had about an 11% drop in test positivity from pre to post. That was not significant. And then in the 9 intervention counties, we had almost a 22% drop in test positivity rate, which was significant and showed a difference between the intervention and control counties. So now there was a lot going on with COVID, and we know that many things could have affected this, but we feel like it's good starting ground for the work we wanted to do, and a good way to frame equity research work that needs to bring large, diverse groups of people to the table. So, not to repeat what others have probably already presented on, but we know that multiple chronic conditions are probably driven by social determinants of health. Things like tobacco abuse or poor diet or lack of physical activity can lead to multiple conditions in individuals. And these things, they're not just happening in an individual. They're driven by things that are happening in the environment, in the local community, in neighborhoods and social groups. And so we need teams that understand the complexity of this and are paying more attention to it. We also know, again, that primary care providers are often attuned to this. They're often practicing in the community. They're often connected socially and culturally in different ways to the community. That's certainly the case in rural communities. And I think my question is, are we involving them in this research work as much as we should? Out here where we have a lot of cottonwood trees and limestone, that's all we have is primary care providers. A lot of times we don't have access to specialty providers. So the work is getting done by individuals who are attuned to things like a socio-ecological model because they're right nested inside of it. So out of Radix Up, we're fortunate to be able to move on into another project called the COPE project, the Communities Organizing to Promote Equity project, and bring our same model of having the local health equity action teams in 20 different counties. We got funding to hire additional community health workers in each of those counties, 2 to 3 in each county. And then also we got resources to actually give to the LHEATs so that they could implement some of their own interventions to try and move things forward as quickly as possible. So this is our 20 counties. Let me tell you a little bit more about our LHEATs and how they're comprised. Again, our goal was to get diverse folks at the table, folks who had networks, folks who were already doing health-related work, And then folks who could do rapid assessment, develop action plans to implement interventions. This grant was able to focus on COVID vaccination and treatment in addition to COVID testing. But again, a lot of our focus was on upstream factors that we thought were going to influence things downstream. And so that's the reasoning for bringing the diverse group of folks together in an LHE, including community members, organizational stakeholders, and community health workers. Okay, so who was at our tables? As I mentioned, those three groups, but diverse folks as much as possible. We wanted that to be the case. That was certainly the case with our research team that was attached to this and working to provide ongoing technical assistance to these groups. We had diversity from urban to rural, but we also had quite a bit of racial ethnic diversity. Some of our state is not very diverse, but in the southwest part of the state, you can see here, there's 4 counties that have over 50% Latinx population demographics now, and that really does require a different approach. And we know that social determinants of health are often driving things there. One of those counties, Seward, which is right in the corner down in the Texas-Oklahoma Panhandle, has 30% of folks that are not U.S. Were not born in the United States. So there's all sorts of issues that need to be addressed there. So what sorts of things would those counties do with the resources that they had available? Well, they addressed things like food insecurity and bought refrigerators to keep food fresh and then distribute it. They improved transportation in many cases and worked with additional partners to try and find new resources for transportation for those in need, or improve places for children to play. So things that the groups came up with were the idea to then drive improvements. And at the same time, these community health workers were doing as much education and facilitation of COVID testing, vaccination, and treatment in an ongoing fashion throughout the projects. The groups, as I said, met regularly to assess things, come up with new 30-day plans on a regular basis, and to evaluate those, which some of our evaluation is still going on for this project. In our urban communities, we had additional things that were brought on board, including free Laundry Love laundry days that got people together and allowed a number of our partners to then try and provide additional resources to individuals and families, again, to try and address as many needs as possible. Next one. So takeaways, we really found that the model was able to mobilize resilience that does exist in these communities. So we wanted to have a strengths approach with this work and tap into that resiliency. And we saw that. We saw a whole bunch of new partnerships formed across all these 20 counties. And then we saw lots and lots of events and activities that targeted those that have historically experienced health inequities. We think these models hold promise for additional studies and for improving things, not just things like COVID, but the things that result in multiple chronic conditions in individuals who might otherwise have better outcomes. So again, I want to highlight the fact that sometimes we don't center things on primary care, both with our research work and our delivery work. Now, in a rural environment, it has to be that way because that's all you have. But some of the healthcare models that have been developed and have been noted to be significantly effective, things like a cystic fibrosis model of a team-based care approach for folks with that condition, or a similar team-based care approach for folks with ALS. I don't think we've developed those yet around a primary care led team that can bring things like behavioral health to the table, community health workers and social workers to the table, pharmacy to the table, a host of different individuals working as a team, but centered around primary care providers who do have an understanding of dealing with multiple issues and multiple conditions, they have to do it in rural environments. And they also understand the social determinants of health. So we're trying to get into the upstream and the outcomes issues. And I think we would like to see more testing of models where primary care providers are central to this. These primary care providers are working in the emergency rooms already and delivering the babies and dealing with the uncontrolled diabetics. And I think we can harness some of that, that wisdom that I think oftentimes is discounted, and use it to improve outcomes for these patients. So I think the more of this we do, I think the more we're going to see that we can take things that are already happening out there in the real world, and put them into play. And the sooner we can, the better. Like I said earlier, I think we want to have diverse teams working together, both healthcare teams comprised of diverse individuals and research teams comprised of diverse individuals, and always supplemented by direct community input, co-ownership by community partners and members. We want to do this work in a multi-level way. Out in the real world, things are multi-level, right? Whether that's in an urban environment or a rural environment, things are multi-level. And I think if we do that, we're going to find that we can improve the outcomes for these patients rather than having care siloed for different conditions and leading to poor communication and outcomes that just aren't as good. So I'll stop there and we'll, I think, go into some panel discussion and additional questions, but thank you very much for having me, and appreciate it very much. Thank you.
Thank you so much to Dr. Maciejewski and Dr. Greiner for those wonderful presentations. I invite both of you to get on cameras for our Q&A time. I also invite people to ask any questions in the Q&A box. I don't see any, so I'm going to ask my first question to both speakers. What do you see as some of the opportunities to move the field of MCC research forward?
That's quite a broad question. A great question. So I think that care models for MCC patients with a diverse array of chronic conditions in the dyads or triads or quadruples or quintuples is really critical. In the population of older adults that I do most of my work in, CMS's tried a whole range of disease management care coordination demonstrations trying to improve quality of care, improve access, lower cost, and a lot of them have really failed to realize their promise. There's a very nice paper by Gerard Anderson and colleagues who have kind of summarized the principles of the most promising sort of principles of effective interventions based on single site or small number of site studies. I think that was in the American Journal of Managed Care, and that has some promise, but I don't know if there's been any interventions that have been really scaled effectively. The PACE program serving older adults, that's financed by Medicare, addresses not only medical needs but social needs, and has been shown to be very effective in the small number of evaluations that have been done on it, but it has not scaled widely because it requires integration of social services and medical services. So that's a program that's quite promising. So I think there may be value in building off of that experience. And I don't think there's been a whole lot of evaluation of how the PACE program has worked in serving, addressing disparities. And I think that's an important area to be able to build on. I don't know, Alan may have other thoughts.
No, I think that's great. We've seen some of that value of those PACE programs here. I think it's been mostly urban around here that we've seen that deployment. I think we've heard of some things that I think are going to move this field forward in the last 2 days. And there was a lot of talk about about payment reform yesterday and those kind of things. I think what I might not have articulated super well in my talk, but I think is crucial to this, while we're waiting on payment reform, sometimes we need that urgency to just keep trying things. That community partnership and co-ownership with community partners and input there brings a lot of that urgency forward at times. And with COVID and some of these projects we were able to do, we found that there was urgency, right? Because we had a pandemic right in front of us. And so the people that got on the team and were successfully integrated into this diverse team were people that were not only going to be trying to accomplish research outcomes, but also accomplish outcomes that the community partners wanted to see and were practical, which, it's very consistent with traditional CBPR, but that urgency allows you to keep it moving forward. And I think we've got to do that and not necessarily always just wait for payment reform, because we seem to never get there on that topic.
Thank you both. Great insights. So now my next question is specifically to Dr. Maciejewski. How do you choose which types of specialists to invite to collaborate on your MCC study?
Yeah, great question. So most of my work has been focused on cardiometabolic conditions, and certainly studies of obesity and management of obesity. And so because those are the conditions of focus, primary care providers, pharmacists, cardiologists, endocrinologists all seem very natural partners, because those are the providers often seeing these patients. If we were focusing on cancer, obviously oncologists would be more relevant, or if we were trying to evaluate the intersection of mental health conditions, which we have done in one study, we might involve psychiatrists or psychologists. So I think it's really driven largely by the types of providers that often are seen by the patients of interest in our work. I think pharmacists can bring particular insights in a lot of this work with the MCC patients, because polypharmacy is such a common challenge for these patients. And pharmacists, with the increasing recognition of the value of medication therapy management and comprehensive medication reviews, pharmacist researchers or pharmacists just practicing in the community can bring really valuable insights that complement the insights and experience of clinician providers. Yeah.
Great, thank you. I think Dr. Marshall Chin commented that rural research places issues of geographic areas that differ by market, context, culture, local history. So for rural MCC health equity research, any thoughts on the effects of these factors and how they might be studied? He did not specify who he's asking it to, so it's to either of you. And please send your questions in the Q&A part, not in the chat.
I could try on that one. It's a great question. I think that, in the work I've done over the years, I have seen lots of similarities in health equity issues that we uncover between urban areas and rural areas. What we don't have necessarily in rural areas, at least in my part of the country, is structural and systemic racism, which is crucial to the work we do in urban areas. As many of the presenters pointed out yesterday, it's just huge to have some historical context and bring that to the table as you're doing this work. But I think we have class issues, class discrimination issues, and discriminatory policy issues that have affected rural America and just don't get talked about at all in terms of how some of the libertarian sort of philosophy stuff that was talked about yesterday and the capitalism approaches that are tied to that have left rural America behind, and they're creating lifespan issues too, in terms of the geriatric population that's there. So I think we have to attend to these local contexts and the history issues, as Dr. Chen mentions, and really bring them to the forefront and not be shy about talking about these things, just like we're not being shy now about systemic racism, it has to keep being talked about, even though there's, we're also facing a backlash against some of this stuff. I mean, you should see some of the things that go on in some of these rural communities in terms of people don't even want you to use the word equity in the work. And so that can be really a challenge to sort of speak truth to power on some of this stuff.
Can you just give me an example of what you meant by classism?
So yeah,
in rural area context, I know what classism means, but
yeah, there's I think there's a sort of a bias that occurs in certain parts of the United States where wealth tends to migrate away from rural areas, and once that wealth migrates away, a lot of the policy making and the power structures that used to create some equality between large population centers and smaller ones, it goes away over time. And people even though the smaller communities may have some political representation, they're not understanding that a communalistic approach is going to be necessary, or their communities will keep shrinking and keep losing resources. And that's what we see happening in these communities. And that's when then the social determinants of health needs and drivers really create worse equity issues in the communities. I hope that kind of answers the question.
Yeah, thank you. This is really helpful, very helpful insight. I guess there's a question from Preeti Zanwar. I wonder what specific non-clinician team members would be complementary to bring together from a population level standpoint. The workshop on MCC seems to focus on clinicians mostly. Anybody would like to answer that one?
Yeah.
And then we have to end.
Go ahead, Matt.
Oh, I'll be quick. I think having patients with the relevant conditions as well as the caregivers who are engaged in helping them is really critical. Caregiver perspectives can be uniquely insightful, and certainly understanding the experience of caregivers and how their own ability to manage affects their ability of being able to self-manage affects their ability to manage the care of their partner is critical. Alan?
Great.
Yeah, and I think, we've had a lot of public health folks involved in our work, and that gets left behind too. We're not working hard enough to create bridges between clinicians and public health professionals at say county levels or state levels. There's a great opportunity to bring that involved in, and having community health workers involved in this work too is crucial, because they understand at least neighborhood and sort of micro community issues that are population level issues. I could talk about this all day long, but I think those are two of the folks that need to be part of these teams as we move this forward.
Well, thank you so much for your valuable insights. We have to wrap this right now because we're above time. And I'm going to give this to Dr. Sandhya Wanam, who is going to moderate the next session. Thank you all.
Good afternoon, everyone. We will now make a transition to session 5, which focuses on analytical challenges. We'll start by discussing methodological challenges and approaches to studying Latino health equity by Dr. John Hensman of Oregon Health and Science University. Then data analytic considerations by Dr. Daniel Sarpong of Yale University School of Medicine. Community engaged approaches to inform research by Dr. Manali Patel of Stanford University School of Medicine, and culminating with conversations on health equity in patients with multiple chronic conditions and cancer by Dr. Laura Pinero of Cornell School of Medicine.
Good afternoon or morning. My name is John Heinzman. I'm a family physician and health services researcher from Oregon Health and Science University. And I'm going to talk to you today about methodologic challenges and approaches to studying Latino health equity and multiple chronic conditions using electronic health records. We have a center called the Premier Center, which focuses on Latino health equity in primary care. Nod to my center co-director and thought partner, Miguel Marino, who also is an expert on many of these topics, and my other mentor and colleague, Anna Quinones, a gerontologist, who's an expert and has influenced me quite a bit. Our major sponsors and funders, just for purposes of disclosure. And then just what we do observational work in Latino populations cared for in a single network of community health centers with a shared EHR. We focus on common conditions, many of which are people have multiple. And we also try to understand the social and community context that may impact healthcare utilization, which is relevant to my presentation today. And what this talk will be is we're going to talk about a couple common issues we face. Two really, so in the, in multi-level observational design, looking at community context, there's two kind of sibling ideas. One, the clinical model of evaluating social risk that has become very prominent, but also the kind of the paired study design issue of doing contextual community-based work, bringing in community data to understand healthcare utilization for populations undergoing health inequities, but specifically with multiple chronic conditions. And then also just then discuss have a brief discussion of missing data in electronic health records, but specifically around the idea of missing disaggregated data in Latino patients. So, first, this is a recent review of models of care for individuals with multiple chronic conditions. And while it revealed no, great evidence-based work, it highlights the idea that understanding social complexity in the midst of medical complexity is very important in assessing and addressing social risk factors. Is a prominent approach, and we again talking about two ideas: the clinical care model of assessing that risk, and the larger study design issue of using conceptual models to try to assess multiple levels of influence. The latter demonstrated by some popular conceptual models that we use. Now, on the left is the World Health Organization social determinants of health model. The right is a model by Taplin at the NCI at the National Cancer Institute. That's really for cancer care, but is very applicable to our discussion here today as well, looking at multiple areas of influence. But first, I wanted to talk about start off with a discussion of this care model of assessing social risk in primary care in populations that have a lot of multiple chronic conditions, and go through a couple scenarios that we've encountered, colleagues have encountered, that show kind of the state of where this is and the evaluation of it and some of the current dilemmas and knowledge. So colleagues of ours several years ago rolled out social risk screening tools in our network of community health centers. And it's been about 7 or 8 years. They've studied the rollout and implementation of those tools across these, as that has grown significantly over the last 7 years, increasingly to large numbers of patients. So you'll see it now that those numbers on the right are roughly current. 1 million patients, 2 million encounters, clinics 1,200. That's hundreds of health systems, which obviously health systems with their own workflows and governance, and which makes the evaluation difficult. And in 34 states. But they did a follow-up analysis several years later that looked at just looked at race, ethnicity, language preference among those who were screened. And this is a low-income population with high degree of social need. And even in this setting where there were lots of social needs across the board, even looking at who was screened and who wasn't. So Black patients, Hispanic or non, were twice likely to screen as white patients. And then Hispanic white patients, much, much less likely to screen than non-Hispanic white patients. And so the idea of the knowledge base is still quite fledgling, and how screens and how and what we ask who and when and whether it's effective. And it's cliche just to say, well, more is needed, but more is needed. We need to keep doing this in partnership with communities to understand this model of care for caring with complex patient populations, and how the assessment of social complexity can aid in the evaluation and treatment of medical complexity. But there are additional layers of challenge. That same group of colleagues evaluated essentially the comparison of community risk with individual risk, social risk, that is. So pairing these ideas of evaluating kind of conceptually larger levels of influence, but with also directly provided social care. And this basically uses the social deprivation index, a validated index of social deprivation. And in that area with the red circle, you'll see Q1, Q2, that's quartiles. Those are basically the least deprived neighborhoods by this index. And in patients, these low-income patients in those neighborhoods still had at least one social risk factor identified on individual screening delivered in the clinic. And this just to underscore that as we are pairing this study design concept of understanding what a community is facing and how that impacts medical complexity, and the individual care model of trying to know an individual's risk, that we probably need to cast the widest net as possible, understand both of those, collect both of those as much as possible while we are understanding which ones are most salient for medically complex patients or patients with multiple chronic conditions. But to complicate matters, we actually looked at a kind of an analogous study that looked at, now this is children with asthma. Now many of them were obese as well, so they technically did have multiple chronic conditions, but it's a childhood population. And to see whether the fundamental research question was whether community economics or family economics was more highly associated with the care they received for their asthma. And we looked at visit rates, that top rectangle, albuterol prescriptions, the second one, third one, inhaled corticosteroid rates, then an odds of ever having an inhaled steroid for those for whom it was indicated. The red and green is household economics, like a level, income level, and red and purple and blue is economic or community level, and all roughly in the same bracket of percent of federal poverty level, and the comparison was higher, like I think over 200% of the federal poverty level. And what you see here is the only thing that had a significant association with care use was actually neighborhood economics, not family economics. Now this is there's a lot to say about these findings. They're far from kind of really definitive or useful yet, but they underscore the need to, in different conditions, we're evaluating utilization and eventually and outcomes, the need to understand individually reported social risk as a direct care measure and larger community factors potentially in order to understand patients' course. And so just kind of adds fuel to that fire of needing more and more information. But then there's another, wrinkle that when we're having study designs that consider society, community, neighborhood, those kinds of things, and the people move. And this is actually a salient societal feature. We're a mobile culture at all economic levels. And on the left is some exploratory data about addresses, which are used to link patient records to community factors. And it shows basically that changed addresses, like not original addresses, were probably at least half or more of the addresses present in the record. And so so how do we evaluate that? How do we evaluate mobility and healthcare utilization? And we've done a couple of ways. This again is these are children with asthma, many of them are obese. So again, they do have multiple chronic conditions, but it's children. And at the bottom, you see, we just looked at number of moves and how it related to their care. So, and the more moves, the less visits they had, the less likelihood they had of influenza vaccinations or rates of influenza vaccinations. But up above, interestingly, as we evaluated basically the deprivation of the neighborhood they moved to. So whether they moved, if they moved within a highly deprived area or it moved into a highly deprived area, that actually was associated with slightly more care. And this is just one way we've approached it. I still are trying to understand the effects of community on care in patients with multiple chronic conditions. And again, more to know, more in more populations, in more conditions. I think this is just an initial foray into some of these issues. But there's also the issue of missing data. This is a common issue in all research, but not EHRs nonetheless, because we're not often we're not directly involved in the collection, and so handling missing data in the analytic phase is an important issue. These are 4 kind of basic ways to handle missing data. I want to talk about an additional one, but these 4, complete case analyses, basically throwing out records with data, single or multiple imputation methods, and then inverse probability weighting. And this has been written about. We had a paper about this, and people can go and do reading. But there's a specific missing data issue in Latino populations where we work, with whom we work, and that's about data disaggregation, specifically around heritage group and nativity. So missing this around not having good data about subgroup and nativity. And so, while in our network, we have multiple low missingness in some important variables, we don't have good data in nativity, subgroup generation, only in a fraction of our patients. And that is a pressing priority for understanding healthcare utilization and outcomes in patients with Latino patients with multiple chronic conditions. This is underscored by a preliminary analysis we did that used the data that we had that showed some provocative differences. So this is looking at, we have about 10% or so of Latino patients who have a country of birth in our record. And what we did is we compared the prevalence of problemless diagnoses of cardiovascular disease or risk factors between U.S.-born Latino patients, foreign-born Latino patients, and Latino patients without a place of birth collected. And there were minimal differences, a couple small significant differences between those groups in the prevalence of those diagnoses in their EHR. But when we take, and forgive it, I know that the figure is a little bit of a different scale, doesn't have error bars, but we just take the foreign-born Latino patients and we look at the countries that had the most patients, those differences widen. Not in all conditions, but for hyperlipidemia or hypertension, all of a sudden you see 10 or 15 point differences, or slightly more, that all with additional significance. Which is, again, this is only a proportion of the patients in our record, but these differences do underscore the need to have that data more, so we can really see if those differences are real. And we're approaching this in multiple ways. So obviously, there's some basics, good description of what we do have, trying to pilot the additional data collection. But there are, Dr. Marino has led on our team the use of machine learning techniques to estimate population probabilities, using other inputs, using surname, using community level data like community subgroup data, in order to estimate population characteristics, not predict individual status. And preliminarily, that approach has been promising. And this is a pediatric population, but where he was able to essentially estimate with a high degree of accuracy nativity, and specific national nativity in that data set. And that needs, again, to be repeated and explored and used really to then inform future data collection efforts, not to predict someone's status, someone's individual identity, but to then help us know what data needs to be collected more completely in the electronic health record. And so that's a very brief treaty of that, but that's a very specific missing data issue that.
Okay, this presentation is titled Data Analytic Consideration and Optimizing for Persons with Multiple Chronic Conditions in Research and Healthcare Delivery. The presentation outline will first address public health implications of this situation, look at a hypothetical case, and then discuss some conventional analytic approach, and then further look at descriptive analytics, where we try to further understand the data, and then propose 3 alternative analytic approaches, and then conclude with a summary. So in terms of public health implications of multiple chronic conditions, the co-occurrence of two or more conditions, or typically known as the multimorbidity, especially common in elderly people. Approximately 2/3 of persons at retirement age suffers from at least two chronic diseases. Again, this is very important to study because therapeutic management of these conditions is often complex due to high treatment burden for health outcomes, impaired functional status, reduced quality of life, increased health care utilization, and higher rates of mortality. The classical single disease paradigm might not be adequate for patients with multiple chronic conditions, partly because these strategies, which are used for public health and also for clinical healthcare guidelines, may be incomplete and ineffective for these type of patients. Thus, identifying patterns of disease combinations and the characteristics of persons with similar multimorbidity patterns may effectively arm public policymakers and clinicians to address the needs of this population. The cutoff points of multimorbidity is not uniform. However, others have suggested the use of two or more or three or more of these conditions as a way of defining multimorbidity. In terms of a hypothetical case, we're going to assume that we have a team of clinician scientists who are conducting a study investigating whether 7 common chronic conditions significantly correlate with the following outcomes: quality of life, disability, cognitive function, and mortality. These 7 chronic diseases are based on reported 12-month medical diagnosis of depression, asthma, COPD, angina, stroke, hypertension, and diabetes. A number of socio-demographic information is collected as covariates, and these are age, gender, education attainment, household income, which is categorized into quintiles, where the first quintile indicates the lowest level and the fifth being the highest, and then marital status. So conventionally, when we look at these situations, we typically will model these relationships using a linear model approach, where theta equals some function, a linear combination of a vector of covariates, which are denoted by X, and a vector of the chronic conditions, which in this case, we're assuming we have K covariates and J chronic conditions. The approach in terms of the analytic plan is that if the dependent variable is continuous, then we would use a multilinear regression approach. If the dependent variable is binary and therefore we use a logit, then we would use a multivariable logistic regression. However, if the outcome variable is counts, where it follows a Poisson distribution, then theta, which is the natural log of the mean value, would then result us using multivariable Poisson regression. So again, for us to first understand the data, we're going to use the Framingham study teaching database, which is public domain, to sort of demonstrate the importance of first doing some descriptives in terms of these chronic conditions to fully understand the patterns before doing the modeling piece of the analysis. So in this case, this is first approach, which is we're calling A, we're looking at 4 different chronic conditions: hypertension, CVD, stroke, and diabetes. The goal then would be for, and since we're using gender as the main exposure variable, we would then stratify the sample by men and women. So the first thing in this approach would be to sort of run the prevalence and then rank them. So in this example, whether we're looking at it by gender or the total sample, and we're just focused on the total sample for now, we see that hypertension has a prevalence of 73.3%, so it'll be rank 1, followed by CVD at 26.1%, then stroke at 9.4%, and then diabetes mellitus at 2.7%. So we realize that the prevalence of diabetes within this group is very low. And again, this gives us some sense of what we might want to focus on. An approach B would be to sort of look at, instead of the individual, look at the burden of the disease or the burden of the condition. So in terms of the burden of the condition, one would look at the count. So in this case, we would look at the number of chronic conditions that an individual has. If they have none, the random variable that we're creating will have a value of 0. If they have one of those 4, only one of those 4, then the value would be 1. And if they have all 4 of them, the value would be 4. So again, in this instance, we can sort of, a third approach, which we're calling approach C, will be to look at all the possible combinations. So with these 4 conditions and looking at all the combinations, we actually are looking at 16 subgroups. This can become very burdensome, particularly when your sample size is not very large. This may have a utility when you have very large data sets like big data and you're mining the big data. So this might not be the approach to take. So then this leads us into the alternative approach that we might need to take. The first one being the index method, then patterns of diseases, whether we're using cluster analysis or the latent class analysis. And then the last is CART, which is the classification and regression tree approach. So if for the outcome variable is dealing with mortality, then we could use an index approach. And this index approach, we can then use indices like the Charlson Comorbidity Index, or in the case if we're studying the veteran population, use like the Veteran Age and Cohort Study VAX Index. What they also found, some of the researchers who have used this cohort, the veteran age and cohort, have found out that a combination of the VAX and the CCI, the Charlson Comorbidity Index, actually seems to have great advantage. The VAX uses a lot of general health information, also HIV type information and other clinical information. The CCI is a weighted sum of 19 comorbidities with weights ranging from 1 to 6, and these are used to come up with this index. Once the index is established, then one would use a Cox proportional hazard model to predict either a 5 or 10-year mortality rate. Alternative to using the index method is to use the latent class analysis. The latent class analysis is based on structure equation modeling, where in this case, the latent groups are actually based on correlations between these chronic conditions. It's also based on the assumption or the hypothesis that certain chronic conditions cluster together. And this avoids creating all the possible combinations, where in the previous example, we showed that just with only 4 chronic conditions, we will be looking at 16 subgroups. If, for example, the outcome variables, the chronic conditions are based on continuous measures, such as like blood pressure, maybe fasting glucose, then the equivalent to the LCA would be the latent profile analysis. And again, in terms of selecting the most optimum number of latent classes, this is based on the adjusted Bayesian information criteria, the BIC, and the consistent Akiaki information criteria, the CAIC. Again, with the latent class analysis, basically, if we take, in the case we dealt with We would list all the chronic conditions. We would look at the prevalence and look at the standard deviation. However, if it's based on a complex sample or survey, we would report the standard error as opposed to that. And then for each of the chronic diseases, we will look at the probability that those cases also are affiliated with some other comorbid conditions. We also look at the mean and standard deviation of co-occurring conditions, and this is very important. Your table 2 then would display the various latent classes and using the fit statistics, whether using the CAIC or the adjusted BIC to select the best optimum number of latent classes. After we've identified the number of latent classes, we would then use some form of labeling to label these classes. And so this diagram shows the classes that we come up with, the class membership probabilities, those that had up to 1. And then for each of those, we show the item response probabilities for those. And again, once we've established these, then the next step would be to sort of use our traditional either linear regression, logistic regression, Poisson regression, or the Cox proportional regression. The benefit of this is it's a very powerful statistical tool. It's used to identify subgroups of individuals with shared characteristics and therefore could benefit from common interventions. The limitations are that this is based on probabilistic modeling as opposed to this, being deterministic. And also there is the potential of what we call naming fallacy, which is finding the right descriptor for the class, for the classes based on the class membership. So then the next third thing we're going to talk about is the classification and regression technique. This basically tries to detect the underlying structure of the outcome variable using improved tree-based graphical model. It's much easier to interpret this kind of thing, and it's a very suitable method for analysis of multiple morbidities. The diagram to the right shows how these things branch out, the form of tree branching, and therefore starts with the more critical factors that influence what we're measuring. The challenge here is that there could be overfitting, but there are techniques which are called pruning, which are used. And again, there are other methods by which we can actually improve this. The one for the case where you're dealing with categorical data is called the chi-square automatic interaction detectors. And for continuous variables such as interval or ratio scale variables, we use the conditional inference tree. So in summary, what we can say is that the classical single disease paradigm might not be adequate for patients with multiple chronic conditions. Hence, we need non-conventional analytic methods to identify patterns of chronic conditions to make it relevant to investigators, clinicians, and policy makers. The descriptive analytic technique is a first step to help us understand what is going on. The other analytic approach is to analyze in the MCCs, deriving indices, the latent class analysis to create optimum number of latent classes, and the CAT method. The benefits of these analytic methods outweigh the limitations. Thank you, and these are references that you can review and get some more information. Thank you.
Hi, thank you very much for the opportunity to present on community-engaged approaches to inform research in multiple chronic conditions. I plan to use cancer as an example because it's very complex, just as multiple chronic conditions is, and requires good data in order to determine the impact on the data out. As many of you know, care in the United States is completely fragmented. And this leads to silos of data that don't follow any patient population. Data thus also is fragmented. This is an example of, for example, wearable data that isn't housed or follows patients into the electronic health record. We also know that the electronic health records are siloed, and even when we do have sharing of electronic health records, there are labs, there are prescriptions, there's clinical trial data that's often not following the patient in their care journey. Complexities of care are becoming increasingly common, and this is particularly the case for chronic conditions, but also, for example, cancer is an example where we have multiple different specialists who may be using multiple different platforms, and the data necessarily is not necessarily linked. We, for example, in each cancer, so take lung cancer, we know that there are these bubbles of where people are receiving care, again, in silos, from detection to diagnosis and staging, and then all the aspects of treatment. And just to hone in on this complexity, each of these bubbles has its own complex care process with its own data that oftentimes is not linked even within one tiny care process. So this is an example of detection where we see that there's a pulmonary nodule that needs workup. There are multiple different steps that are required to be able to get the pulmonary nodule worked up, and the data that follows, and then also these silos within the steps of data, such that we have complex systems and data that's not necessarily accurate or complete. It's no wonder then that with every clinical advancement we see in healthcare, we also see this inadvertent worsening of healthcare disparities. We know that for cancer care, for example, with treatments that are rapidly changing, as well as complexity of care that requires multiple specialists and multiple different labs, for example, that our care and our ability to be able to address health equity is significantly suffering. I think that a unique aspect of cancer care, if you think of it as an example of a chronic condition, is really that we have this wonderful data registry where the surveillance epidemiology and end results program, for example, helps us to elucidate the denominator such that then we're able to ask important questions that can help us to evaluate healthcare equity as it relates to treatment or to cancer stage, or for example, to screening. Unfortunately, registries alone are not enough. There is missing data even within our cancer care registries, including hospitalizations, which are an extremely important aspect of care and can help us to inform additional ways to address health equity. We have novel linkages, for example, in my group that we have utilized, where we have been able to link claims data, for example, through the Office of Statewide Health Planning and Development to evaluate hospitalizations and acute care use that are increasingly important for achieving equity in cancer care. Much of our work has also looked at these novel linkages to inform what's happening in particular care systems. Are there particular systems, for example, integrated health systems, that may be better performing at addressing racial and ethnic disparities in cancer, that may be then an example for how to deliver care and how to create interventions outside of the system? We also know that it helps to target interventions, especially by race and ethnicity. Not that we want to silo our interventions, but it also helps to address in limited funding and capacity where we should begin to be able to address urgently interventions to overcome race and ethnicity disparities. So for example, looking regardless of diagnosis, what's happening at the end of life for many patients? Is there large rates of acute care disparities by race and ethnicity? And how can we begin to overcome some of these issues by developing targeted strategies? Most of my work focuses on community-based participatory research methods, where we integrate the methods to develop interventions that then can go on to achieve health equity. And we know that the community not only knows the problems within the community, but also the solutions. And what we've heard increasingly regarding data and analytic challenges as it relates to cancer and other chronic care conditions is that there's a historical misuse of the data. There are often missing data elements that are important for the community that often lack the desire and the impact on community benefit. We also know that there's lack of ownership and access. There's implications for privacy and security, and the importance of developing and leading and having the community lead, not only in the problem definition, but also in which data elements are important and need to be collected is really where our group has begun to create interventions that we think are largely successful because of this deep community involvement. One example that was funded by the NIMHD for me through a K award was looking at how to unite partners and stakeholders to begin to not only create data infrastructure, but then to be able to create interventions that can address cancer inequity. And so in this particular project, we were lucky to have payer organizations such as a labor health union, a health plan that had claims data and could help us to identify where there were high rates of low value care. In addition, we were able to utilize clinical data from the community practices and the clinical practices, both from the primary care clinics as well as from the clinic practices in the cancer clinic space across Atlantic City and Chicago, to then link in data such as cancer stage, which is missing from claims data from healthcare payers. And then finally, we were able to utilize data from the health employer plan, so the labor union organizations collect a swath of data regarding environmental toxins and employee-related and employer-related interventions and data such as health-related social needs screening, food insecurity, income that are also crucial. Together, we were able to identify, utilizing this data and creating kind of a data warehouse that united all of the partners in the data such that the missing elements were overcome. We then were able to develop an intervention that addressed health-related social needs screening. We were also then able to utilize the same intervention to address advanced care planning and end-of-life cancer care delivery, and then be able to measure the effect, which we just published this year, after we developed this very targeted intervention. Again, all because we were able to unite the partners to ensure that the data matched what the community needs were, but then also to develop a very targeted intervention and have an infrastructure such that we were able to evaluate the impact. Another example is a study that's funded by the California Initiative to Advance Precision Medicine, which we just completed, in which we began a county-wide approach to increase access to high-quality cancer care for low-income and minoritized populations in Monterey County in California. And again, we started with, just this very humble approach to understanding what data elements are necessary to create an intervention, then co-develop an intervention to address these health disparities and measure them. And what we heard resoundingly from community members was the lack of food insecurity interventions and targeted interventions to actually screen for food insecurity once patients have moved into the cancer space out of the federally qualified health clinics. We also found that there was a significant need to be able to address family history, cancer risk factors to help inform interventions for cancer genetic screening. And then from the clinical aspect, we were missing simple things such as being able to evaluate receipt of evidence-based treatment as it relates to precision medicine. Again, a clinical advance that requires multiple steps, including precision medicine testing in order to be able to receive precision medicine treatment. And that this data needed to be collected longitudinally. And so through the community, through Community Advisory Board, we then co-developed intervention components where there were strong areas of need. So for example, precision medicine access really wasn't getting to the community members, including education about precision medicine, ensuring that precision medicine testing was being completed, and then also on the off end, ensuring that the treatments that corresponded to that testing were being delivered. We found a significant intervention effect, I think, because of this large community involvement, deep community involvement, where we went from 0% of patients before the intervention being screened for food insecurity in the cancer clinics to 100% countywide. We also found that this screening then led to a development of an intervention that we created with the UCSF to begin to address food insecurity in addition to supplemental food programs within the county. And we were able to decrease food insecurity amongst people that were being treated for cancer by over half. We then also, largely due to the community input, really focused an effort utilizing community health workers on increasing clinical trial education. That led then to improving clinical trial participation. And then specifically as it relates to clinical care delivery, we began to address molecular testing and precision medicine testing for cancer which is incredibly important in determining better outcomes universally. And we found that we were able to not only improve molecular testing in the county for low income and minoritized populations, but then that also led to correspondingly increasing the precision medicine treatments that are needed to address the molecular tests that may have been found. We've heard resoundingly from community members that while the population data is really important in terms of the large data that we have at a population level from registries, that trying to inform and using that data to inform local interventions really requires local data. And so, for example, we've been using California health maps where we've been able to find pockets of where there are disparate disparities, even with communities that may have large disparities overall. So tackling and addressing small chunks of where we need to identify and focus efforts. So for example, in persistent poverty areas, specifically within census tracts in Fresno, we are now addressing upstream risk factors for lung cancer within these areas, given the fact that the lung cancer risks and the rates of mortality are actually twofold from one census tract to another within the same city. We've also been addressing air quality issues, especially amongst individuals based off of where they work and live, which can be extremely different in terms of many counties, for example, down the street or a neighborhood down the street. There are disparities in terms of that level of air quality, the impact of wildfires on the health of minoritized populations, for example, based off of how close they may be living to a major highway, in addition to the poor air quality in the region, in addition to what we're seeing now with climate change and wildfires. We are now launching this large initiative focused not only on climate change, but then also addressing the upstream risk factors for lung cancer, driven by local data to inform interventions within the area. So overall, care is increasingly complex. Cancer care is just one example of multiple chronic conditions. Registries, when we have them, are great. They can help to inform modifiable targets at the large population level, but we really know that local data is absolutely crucial to informing successful solutions. And it requires deep community engagement to ensure that we're collecting the right data to be able to achieve health equity. I'm excited to answer questions and really appreciate your time.
Hi, my name is Laura Pinheiro. I'm an assistant professor in the Division of General Internal Medicine at Weill Cornell and a cancer health services researcher. And I'm here to talk to you a little bit about achieving health equity in patients with multiple chronic conditions, really highlighting some challenges in some of these research questions and ways that we can address them. So I'm going to start off describing a little bit about the burden of cancer in the United States. So there are more than 17 million people who are alive with cancer today, and 70% of these have a co-occurring chronic condition. The most common chronic conditions that we see in cancer patients are heart disease, diabetes, hypertension, arthritis, and COPD. Most of my work is really focused in the diabetes space at the intersection of cancer and diabetes, so I'll be focusing on that in the next couple of slides. Patients with diabetes and cancer actually have a 50% increased risk of overall mortality compared to patients with cancer who don't have diabetes. And this has been shown in a variety of studies. I'm actually citing a systematic review here. And so because my work is really focused in health equity, this led me to wonder if racial and ethnic minorities with cancer have different patterns of diabetes management that might be driving some of these poor outcomes. So my team and I published a study in the Journal of Cancer Survivorship looking at racial disparities in diabetes care among the individuals diagnosed with breast, prostate, and colorectal cancer. And we used SEER Medicare to study this, which is cancer registry data linked to Medicare fee-for-service claims. We found that after a cancer diagnosis, only 42% of patients were receiving the recommended diabetes management indicators, such as HbA1c tests, LDL tests, and eye exams. Black adults with cancer were 20% less likely to receive these recommended tests compared to non-Hispanic white adults. and Hispanic Latino adults were 13% less likely to receive these tests than their non-Hispanic white counterparts. And these differences and declines from before to after cancer were not explained by socioeconomic status or clinical need. So they're really suggestive of disparities. So this led us to wonder if the different patterns of utilization that we see in the year after cancer diagnosis were related to worse outcomes. So we looked at racial disparities in diabetes-related emergency department visits and hospitalizations among cancer survivors. Again, we're using SEER Medicare for this study, and we found that among 40,000 Medicare beneficiaries with diabetes and cancer, just over 10% had a diabetes-related ED visit or hospitalization in the year after their cancer diagnosis. Black adults were 50% more likely to visit the ED or be hospitalized compared to non-Hispanic white adults, and Hispanic adults were nearly 40% more likely to visit the ED or be hospitalized compared to non-Hispanic white adults. And so some of these observations really lead us to want to look further into this and why it might be happening. And so I'm going to shift gears a little bit now that I kind of set the stage and talk about some challenges in answering these questions in using data. So some of the challenges that we see. First are issues related to care coordination. And so as you can imagine, someone that has diabetes and cancer has to have relatively well-coordinated care. And so poorly coordinated care increases risk for hospitalizations and emergency department visits, which we showed are higher among Black and Hispanic cancer survivors compared to non-Hispanic white cancer survivors. It also increases risk for repeat tests because of lack of coordination and potential prescription drug interactions. And some of the work by my colleagues and myself have shown that Black adults and Hispanic Latino adults report more deficits in care coordination than their non-Hispanic white counterparts. So this could be contributing to some of these problems. And they also report worse experiences with their hospital care than white patients do. But how do we measure care coordination sort of on a larger scale? That's definitely challenging. And so I wanted to discuss some potential ways to do that. First, there are some self-reported measures. So there's the MCAPS 8-item care coordination measure, which asks about your personal doctor having medical records and other information during your care visits, talking to you about your medications, being informed and up to date from other specialists, and following up on test results. So really this asks questions about repeat blood tests, x-rays, other tests, problems with medications, and you can also ask about ED visits and hospitalizations. But it's not always feasible to do a survey of patients, and maybe you aren't prospectively collecting data. So if you wanted to go and look at existing data, how would you measure care coordination then? So there are actually insurance claims-based measures of fragmentation, which is sort of a way for us to get at this issue of care coordination. So one that I've used in my prior work is called the Bice-Boxerman Index. And this is the way that you calculate it. And so it looks at the number of visits in the previous 12 months to the number of providers and looking at sort of the concentration of those providers. So this index captures dispersion, which is a spread of a patient's care across multiple providers, and the density, which is the relative share of visits for each provider. So in my prior work, we've reversed the direction of the index so that higher values indicate more fragmented care and lower values indicate less fragmented care. And so here is an example of some findings that we did looking at the Bice-Boxerman Index. And you can see here on the right side that individuals with with cancer have more fragmented care than those without cancer. They also see a median of a median of 11 visits per year compared to 9 visits for the non-cancer group. They see on average 5 providers compared to 4, and a smaller share of their visits are with their most frequently seen provider. And this suggests that fragmented care is more prevalent among cancer survivors after we adjust for demographics, socioeconomic factors, and comorbidities. And because of this, they might be more susceptible to the harms of fragmentation because they're already dealing with such a profound illness. And so measuring care coordination is one piece of this, but also in doing racial disparities work, we want to take a look at identifying race and ethnicity in existing data. And so there's generally lack of systematic data collection for race and ethnicity, and this really limits us from identifying problems that individuals from certain racial and ethnic groups may experience. And this leads us to make assumptions. We've all talked about, grouping the other or multi-race together, and what sort of implications does that have for our work? And so by not having high quality race and ethnicity data, it really hinders our ability to evaluate the quality of care that we provide patients across different racial and ethnic groups. So a potential solution that I wanted to talk about is using natural language processing. So essentially, we use NLP to extract race and ethnicity from unstructured clinical notes in the EHR using a validated algorithm. And the way that this looks is that basically sometimes a patient will have missing race and ethnicity information, but when the provider describes them in their clinical note, they'll say, Black, male, presents with chest pain or something to that effect, and we can capture that with the algorithm and then reduce the amount of missingness that we see in our race ethnicity data. So I was part of a team that did this a couple of years ago, and we published a paper that compared what the NLP algorithm found for race and ethnicity to the structured notes. And so among a sample of 16,000 patients at New York Presbyterian Hospital in New York City, we found that the NLP algorithm increased the number of Black patients by 26% and Hispanic patients by 20%. So we were able to reduce the level of missingness. And when we compared the characteristics of the patients that were identified in the algorithm versus the structured notes, we found that Black and Hispanic patients identified by the algorithm tended to be older, more likely to be male, and have a greater comorbidity burden. So this really speaks to individuals with multiple chronic conditions and how Black and Hispanic patients may be more likely, be less likely to be identified using structured data. And so I really bring this as an example of the ways that NLP may serve as a tool for addressing missing race and ethnicity data in the electronic health record. So another challenge in conducting this type of work isn't related to social determinants of health. So most health systems don't routinely collect social determinants of health for patients. And we know that multiple social determinants of health in the same individual actually increase the risk for incident coronary heart disease, stroke, heart failure, and hospital readmissions, as well as cancer mortality. And without addressing upstream social determinants of health, we're not really able to eliminate disparities that we see downstream. So there are some potential ways that I think we can get around this. One is using the American Community Survey. And so this allows you to look at different measures more at the structural level, the area level, such as air quality index, food swamps, social vulnerability, neighborhood walking and biking environment. And that gives you a sense, a bit more of a sense of, the conditions that individuals live in. And the way that this works is that the data are collected from at the U.S. household level. They're sort of from the U.S. Census Bureau, and then they're aggregated at the area level. And then you're able to take a look at different area level measures if you have a patient zip code. So you can learn about things like the percent of African Americans across the country, and you can see this nice looking map. This is just an example of different area level factors that you can take a look at with these data. You can also create things like structural racism variables at the area level. And so these are an example. This is an example of structural racism variables that I've created in my own work. So looking at, for example, education. So the ratio of Black to white percent of residents with less than a high school diploma. You can look at unemployment level, the Black and white ratio living in a health professional shortage area. You can look at things like incarceration rates, voting registration, and this really allows you to get at more of these structural factors. And this leads me to my last sort of challenge in doing this type of work is really data harmonization. So it's difficult to compare findings across studies when different measures are used to capture the same or similar domains. So for structural determinants, there are a lot of different ways that we can conceptualize that. And so the lack of standardization makes cross-study collaborations challenging and pooling data nearly impossible. So a potential solution that I wanted to highlight from my own work and experience is through a center, U54 center that I have become a part of. It's called the Social Capital Promoting Multi-Generational Health. So it's called the SOCA Center. And the mission of the SOCA Center is to reduce cancer health inequities and persistent poverty census tracts throughout New York City. And so I'm the research methods core for the center at Cornell, and I have a counterpart at Columbia University. And so our goal is really to ensure data harmonization so that we can facilitate connections across the SOCA Center and Persistent Poverty Network, which is nationwide. And so we employ something called the FAIR model, which is the findability, accessibility, interoperability, and reuse of digital assets. And basically, we're trying to use standardized and valid questionnaires, for example, from the Phoenix Toolkit and Promise, to capture some of these structural determinants of health and really come to a consensus of ways that we can do that so that we are able to share data across different studies and across different PPI sites. And really, we want to leverage standard harmonization techniques to maximize the comparability of the data from multiple studies and sources so that we can really look at some national trends that may be happening. So some quick takeaways from this presentation. First, there are validated self-report and claims-based measures of care coordination, which might be important tools when you're studying individuals with multiple chronic conditions. We should be taking more creative approaches to addressing missing race and ethnicity data because they can reduce bias. We should also consider structural factors that have important implications for our research questions, especially related to health equity. And there are a lot of amazing publicly available data sets that we're able to leverage in our work, and I think that we should be making good use of those. So thank you so much for your time, and I'm happy to take any questions.
Thank you, Dr. Heinzman, Dr. Sarpong, Dr. Patel, and Dr. Pinero for your compelling presentations and thought-provoking work. We'll now shift gears to our live Q&A, and you can also put questions in the chat for responses. To get us started, this is an open question for all of our panelists. I like to ask, what are the most promising advances or new methods to explore and research in healthcare models for multiple chronic conditions?
Well, I think I think what I would say is that I think there are already methods out there that may not be in the biomedical realm, that may be more in the field of social sciences or in psychology. So I think we need to, in the biomedical world, begin to look across other disciplines and begin to borrow from that. I think we also have great advantage that in this era of big data, that we really mine some of this data to sort of help us hone in on new primary data collection. Because a lot of times, most of our, say, your R01s, the sample size is still very limited. So we're not able to do subgroup analysis where we're able to really understand what's going on at some of the, at certain level beyond the overall primary outcome of interest. So I think we need to really leverage technology, methods in other disciplines, and then with all this computing power and availability of data, really leverage that to drive our new research questions and approaches.
I mean, I think we need to go backwards. I actually think health equity is a local issue, and we've gotten so excited about this new technology to do AI and big data. But overwhelmingly, I think over the past 2 years, we've heard that the community wants local solutions. I also think we're done with descriptions. We don't need any more descriptions. We know that there are disparities, especially in, if you silo the conditions and then you layer on multiple chronic conditions, we do not need another study to show us that there are disparities by race and ethnicity, by income, by where you live. We need to have an intent for the hypothesis of what we are studying, if we are looking at data and have to describe, should then have an intent to action. And that means thinking about the people that we need to include as stakeholders at the table when we're designing these research questions, even if it is a data exploration, that we have at least a hypothesis for what we plan to do with the data and how we plan to act instead of describe.
Thank you, Dr. Patel, for that energetic answer. And to your point, how could building capacity in complex healthcare research methods among investigators and healthcare setting personnel from those communities influence the field?
Yeah, so what's fascinating is, my talk focused on cancer, but what was nice about it is the community health workers that we embedded into care cross-sectioned over into the FQHCs, help to coordinate the care, help to address diabetes management, help to address to the clinicians, look, this patient may have an adverse event from a chemotherapeutic that's being provided that wasn't in their med reconciliation list. I think we've done a good job of at least trying to train, and we have videos available where we train every personnel from the step up, including community health workers, on the data collection. We have them have access to REDCap if they're interested. If not, that's okay. We also have community health workers help and learn how to do consents, how to help patients into clinical trial. And so providing that extra layer of research and data methodology, we also invite them to our data analytics meeting, which we have a slew coming into these virtual meetings with our statisticians so they can see what this data input, what we require to actually be able to analyze the data, and then what inputs we need to address or how that data was actually collected. They have those answers better than I do as the PI of the studies.
Thank you.
I just wanted to piggyback on what Dr. Patel was saying. I think the engagement, even when we do all these fancy stuff in statistics, I think sometimes we need to present the data to the affected community and really get the responses back. Because sometimes I think we do injustice to the folks because our interpretation of the data may be coming from a lens that is not incongruent with that of the community. So I think even when we do all this big data mining and the like, which there's a place and time for it, I think we need to engage community. I couldn't agree more, because I think that's where the missing link is. And then also too is, how do we translate this information such that the end user is excited for the uptake? I think we know a whole lot. The uptake is poor because they're not engaged in the translation of the information to the point where it makes sense to them.
Yeah, I also wanted to sort of echo what was said by my two colleagues that spoke first regarding, really engaging patients and community members. I think that,
it's sometimes a challenge, especially if you're working with big data. But my team and I have been trying in the past year or so to really bring each of our findings back to a small patient group for the condition that we're studying, and really getting their thoughts and incorporating that into the discussion section of a paper. Why we observed this, why do you think that might be? And it's just been an incredible experience getting that perspective in the work. And so I really do think that that's a promising way to moving forward.
Yeah, and I would actually piggyback on that. I mean, the promise of big data is not that we would wash out local, the power and importance of local data, and obviously community-driven solutions and interventions. It is to develop a culture where communities actually learn from one another. I mean, that the power of actually understanding how disparities and solutions to disparities manifest across communities and in different communities that may be different on some respects and share some features in other respects. And so yeah, that's the power of understanding how to bring big data to local communities, because there is this, it's of use in the same way that it's of use for investigators. And I guess I just would respectfully disagree with my colleague. And I think there is still room for description, not in some respects, and many there certainly is. We don't need to observe the same disparities, but there's a lot we don't know, we haven't described well, especially about how things specifically work out in healthcare. Or about some of the community level things, exactly which factors play a role in which specific things. I mean, I can think of multiple examples, but so anyway, it's not a complete disagreement, because in some ways we do need to move forward onto understanding how to mitigate these things. But there are still, I think there are still realms where we still don't understand exactly why things are the way they are. So
I would like to add implementation science. I mean, wearing my VA hat, I just, how easy it is for me to be able to see all the conditions and to be able to access the primary care physician when there's an issue. It's a Teams message. It's super easy. I get to see all the records now with the Mission Act and veterans getting care out of the system. It's become the wild, wild west, like what I see at Stanford. But I do think the aspect of, for example, thinking about, like you mentioned, was the organizational factors of what are the uptake features for when you do have a successful intervention that does address, for example, care coordination for MCC, for populations with MCCs. What's the secret sauce of what can be adaptable? What are the core features that shouldn't be adaptable? I think we also really need to invest in implementation science and integrating that into the MCC framework, which I'm glad a lot of the presentations have done over the past 2 days. But I think in the same way, bringing it back to the clinical leaders, that's where we lose, right? We don't bring that dissemination back to the people, the executive leaders that are making these decisions. So in the same way that we think about who's the audience that we need to disseminate this work to begin to make meaningful change, the same thing needs to happen when there are these implementation studies. Who are the people that need to be involved? Are they local policymakers, but also the healthcare leader and the executives who often are not at the table or involved in the discussions about the research that's going on at their own institutions?
Thank you all for your enlightening responses to that question. It sounds to me like inclusion of a constructivist or participatory paradigm into the medical model or general conventional research model would be helpful, particularly when contextualizing research for multiple chronic conditions. To add to that, how could non-healthcare data, for example, community level descriptors, weather, geography, public policy, law enforcement, educational data, and even the social vulnerability index be effectively integrated to create and study models of upstream or multisectoral factors influencing the risk for multiple chronic conditions?
I think very carefully. I proponent of this, and I guess part of my talk was to kind of, in a sense, demonstrate some of the kind of the quagmires you get into when you try to do it, and
essential. And I will come back to, I mean, a theme that is obviously in our session, and some of my colleagues, especially their talks and even talks in the prior, in prior kind of modules, how important the having that community level data be filtered through community participants in the research is pretty important. I mean, I think it's that's just pretty it's pretty foundational. I think and we do need to do a lot of, I think there's that science of integrating clinical and non-clinical data is still pretty fledgling on how we do that. And I you know, Dr. Pinheiro has pointed out how often it's really measuring apples and oranges in some ways. And even when it comes down to just time course and exposure of things and trying to figure out how you merge those two together practically, but also obviously having the community filter those, interpret some of those things, I think it is of utmost importance as well.
I would say that it's critical, right? Again, getting back to the idea of intent to action. You know, I'm a cancer doctor and I do nothing in the climate change space, but our community partners in San Joaquin Valley, where on a given day, the AQI is really horrible in the region. It's in the purple area or the purple region. And then, you know, you layer on wildfires and then you layer on health equity in terms of the jobs that many of these individuals are working where there's not a lot of protection. We've been trying to utilize, again, this local aspect of trying to create maps. And so that's what I showed an example of with that with the Fresno County interlay of looking at kind of the health maps and then trying to layer on as well many of these other factors and social factors that pretend a role, because that's really where we need to begin to go in terms of decreasing all the downstream etiologies, right? The downstream factors that we're seeing in terms of health equity. It's all, I personally believe, due to all of these upstream factors. And so if you're not going to try to go to the moon, right? I think we chose to address going to the moon as opposed to addressing the bigger problem, which is poverty in the United States. I think we really do need to start focusing on some of these other areas of, even if they are quagmires, because they are going to help us to achieve better health overall, especially as it relates to MCCs.
Just real quick.
Oh.
Go ahead.
Oh, thanks. So I completely agree. I think that considering those, you know, more structural upstream factors is completely essential for this type of work. And, you know, most of the policies are really made at that area level, at the community level. And so if at the end of the day, we want, you know, our individual study to move the needle a little bit, that's what we have to be targeting. Is like, okay, well, how is this going to inform, you know, up here, and so that we can, you know, have downstream effects.
Yeah, and just to add to that, I think trying to look at the problem at a unidimensional level is not working. So we need to use a multi-level approach. You know, our interventions have to be multi-level in nature. And I think also too is that we now have to move the science to the point of where it has policy implications. Because a lot of times our discoveries are fine, but the things that solve the problem, maybe at the policy level, is this whole issue of balance between personal responsibility and societal responsibility. And I think with a lot of our health issues, we've only put it at the point where the burden is only on the person. You know, you need to exercise, you need to eat good food, you don't need to eat fast food. But we can change certain things because certain people may not have that privilege or the opportunity. But a policy change will rectify a lot of those issues. But I think our science just stops at the discovery and we don't move the needle into the realm of policy. So this is why, again, we need to be using a multidimensional disciplinary approach where our research engage people who understand policy so they can take that data and translate it where it affects policy. Otherwise, we'll be having the same conversation 5-10 years from now.
To that point, we try to include policymakers in our CABs. Before we launch a project, we find local policymakers For example, the wildfire issue, there's actually a senator who was working with Al Gore for many years on climate change policies. And so finding these niches of advocates that match what the local community may want versus, and the research question has really led at least to local policy changes, and then has branched off to state-based policy, which I think is where we want to go. And then the next step comes back to the implementation of that policy. So then there's research on the implementation part, which again is a quagmire. I'm going to use that term, John, that you, but it is a quagmire, but it does provide at least some incremental change in terms of eliminating the policy level barriers that may inhibit equitable care.
Before we wrap up with this Q&A session, I want to remind you that there are questions in the chat. You can answer those directly. And I want to pose a question to each one of you. If you could share, as an example, one action step or policy change that you would recommend to mitigate health disparities for people with multiple chronic conditions or in research, what would it be?
I'll go. It's probably going to be impossible, but I think a single payer system. The existential greed in healthcare is why we are having this workshop, I think, personally. Like Don Berwick said in his wonderful article in JAMA, we've turned into a society with healthcare payers, and people are, their lives and suffering is largely due to profiteering in medicine. And so eliminating this profiteering, I think, helps. If you look in the VA system, our outcomes consistently, at least for cancer, are a lot better than for veterans who receive care outside of the VA. I think that it would help to eliminate a lot of some of the financial misalignment that is leading to health inequity. So I would advocate for a single payer system.
I would tempted to second that. I very much agree with it. From what Manali said, but as a primary care physician, I'd have to throw in my hat with a shift in support and funding for a better primary care infrastructure. Just agreeing with my previous colleague that multiple chronic conditions land squarely in the primary care office first and foremost. And without that infrastructure being robust, you have increased fragmentation. And so that's probably where I would where my bias lands.
So mine kind of echoes Dr. Patel's in terms of not just single payer system, but like a single electronic health record system where, everyone in this country would be on the same system that you could access with like a single, like a number, I don't know, like a similar to a social security number that you could access everyone's information. I think it could avoid a lot of the harms that we see for poor care coordination.
Dr. Sarpong, what say you?
Yeah, basically, I think that we have to have the political will to make some fundamental changes at the policy level. I think we know what we need to do. Sometimes we just don't have the political will to do it. So I'll leave it at that. I know it's kind of very broad, but maybe that'll be a conversation for another day.
That's a whole nother workshop, but thank you for introducing that. And thank you to each one of you for your expertise, for the enlightenment that you've shared, and for the questions that you've answered. We'll now transition to our next section to be facilitated by Dr. Larissa Avila Santa.
Sandhya, we have a 10-minute break, I believe.
And what I meant to say was after a 10-minute break, we will now transition to our next session.
Thank you. Good afternoon, everyone. We are coming back from a break and we are starting session 6 of the workshop, Unique Settings and Populations. This is Larissa Avila Santa, and I have the pleasure of introducing the panelists. We are going to watch their presentations Their names are Dr. Alexandra Rivera Gonzalez, Dr. Jessica Brilland, and Dr. April Mohanty. Let's watch the presentations and we will follow with a Q&A.
Hi everyone, my name is Ali Rivera Gonzalez. I am an assistant professor at University of California in Merced, and today I will be presenting on studying Puerto Rico healthcare and challenges and opportunities that have come with that. To start off, I would like to provide some context of what makes Puerto Rico a unique population. First off, it is a U.S. territory. It is one of 5 self-governing U.S. territories, yet for many aspects, it relies on federal jurisdiction. And so politically, territories have structural differences to states, which in many ways can become deficits for the local health system. Just to give one example, Medicaid in US territories is funded through a block grant, which is an annually fixed amount of funds, rather than how states receive their funding, which is on a dollar for dollar need-based system. And so this block grant funding structure has repercussions on many aspects for the local Medicaid programs, including provider reimbursements being lower, benefits covered for beneficiaries being more limited, and this also impacts the quality of care many times that can be offered for Medicaid patients. And so another aspect of Puerto Rico is that given its location in the Caribbean as a tropical geography, it's been exposed to numerous consecutive major public health emergencies in recent years. Just to list them out, major Category 5 hurricanes, floods, droughts, earthquakes, and infectious disease outbreaks beyond just COVID, also tropical infectious disease outbreaks like dengue, Zika, chikungunya, etc. So all of these have built upon each other and impacted the health system and its ability to operate efficiently in many ways. And then to provide some context into the overall population of Puerto Rico, which also make it a very unique context, a very unique geography to study or group. So there's roughly 3 million people living in Puerto Rico, of which almost all are Latino and Spanish speaking. But something that is kind of unique here is that the majority are US citizens at birth, given that Puerto Rico is a US territory. And some more population characteristics are that Puerto Rico has a rapidly aging, chronically ill, and majority low income population. So about 24% of the population is 65 years or older. This proportion has continued to grow throughout the years. 42% of the population lives in poverty, and this also correlates to the percent of Medicaid beneficiaries. So imagine more than half of the population is served by these public health insurance programs, Medicaid and Medicare, of which roughly 42% are also covered through Medicaid. And finally, there are high and growing rates of multiple chronic conditions in Puerto Rico and psychological distress. So rates for chronic conditions and psychological distress in Puerto Rico are much higher than many other states and many other subgroups in the mainland. So there's been multiple comparisons of Puerto Rican adults versus other types of Latino adults, or Puerto Rican adults versus other racial ethnic groups across the US, and it's been consistently higher for most of these outcomes, especially when looking at multiple chronic disease burden. And so studies have found that these outcomes have only worsened after the recent disasters that I mentioned in the previous slide. And given this sort of population context, there's also these health system specific issues that contribute to a unique study population. And one of them is that there's a shortage of providers that has been happening for many years. So majority of regions in Puerto Rico are considered medically underserved areas. Providers in Puerto Rico receive much lower wages compared to the states. And this all impacts the quality of care for beneficiaries and patients in Puerto Rico. So moving on to research on the Puerto Rico health system, our group has worked extensively on studying this health system. And so we collaborate with a lot of different universities, including the University of Puerto Rico. So all of our research projects really have been guided by some type of healthcare model. And to list out a few, we've used the chronic care model, the Anderson behavioral model of healthcare utilization, the Donna Median quality of care model, and the patient-centered medical home. And while some of these models have been implemented into our research process, some of them are models that are embedded into the systems which we are studying. They're already present in these systems, and we are simply coming in from a research aspect and studying how they operate and how they are adapted to the local context. To provide one example of one of the adaptations to these health models, we adapted the chronic care model, which looks at system factors, provider factors, and patient factors, and studied how they influence healthcare inequities in Puerto Rico. So within those system, provider, and patient factors, we kind of defined areas that we wanted to focus on for this study. So for system factors, we studied local and federal health policy, including Medicaid and Medicare program fundings. For provider factors, we looked at the shortage of providers, the few training opportunities for providers and for retention of providers, and poor reimbursement rates for those physicians. And for patient factors, we looked at things like health status, chronic disease burden, and socio-demographic characteristics. And each of those avenues led to healthcare inequities in Puerto Rico, but our group kind of moved pieces around for the chronic care model, and we brought in these environmental factors as a catalyst for all of these different mechanisms. And within those environmental factors, we defined the continuous public health emergencies as being one of those key aspects leading to healthcare inequities. And another way in which we applied one of these healthcare models was through one of our projects that adopts a multi-level and multi-method approach to studying the impact of multiple public health emergencies on the local health system. And so for this project, we are using annual claims data to describe utilization trends. We're interviewing a representative sample of Puerto Rican residents to document their individual health and healthcare experiences. And we're doing focus group and key informant interviews with hospital and community health center representatives. So for this last piece of that qualitative component, one of the groups that we've partnered with is the Primary Care Association, or ASPPR, as the name is in Spanish. And so the Primary Care Association is that central agency that oversees local federally qualified health centers, or FQHCs, which are locally known as 330 centers. And so it's important to note that FQHCs play a really crucial role for the Puerto Rico healthcare system. So by definition, they are located in underserved areas, but in Puerto Rico, they serve as the primary source of care for most Medicaid beneficiaries, on top of serving as a safety net for uninsured persons as well. So they are serving a very large portion of the population, given the large proportion of people who are covered by Medicaid in Puerto Rico. Roughly half of the population is being served by these community health centers. And these health centers, the 330 centers, they operate on the patient-centered medical home model. And this model revolves around the idea of care coordination, increasing access to care and guaranteeing continuity of care, offering comprehensive and centralized services, integrating cultural competence into this dynamic, and having patients involved and engaging in that decision-making process for their own health. And one of the main qualities of these FQHCs is that they really prioritize population health, community and population health. So they go above and beyond to protect the health of the communities which they serve. And the way that we have integrated this into our research is by studying how that patient-centered medical home, those pillars of patient-centered care, have reacted, adjusted to, one, the growing demands or the growing health needs within the population, two, the funding constraints in which they operate, given the large Medicaid population that they serve, and three, the increasing number of public health emergencies that affect their day-to-day operation. And we've worked closely with administrators, physicians, nurses, technicians, and many others within these different centers to understand their approach to disaster preparedness, response, and recovery within this model, including any lessons learned and how the patient-centered medical home captured or failed to capture these changing needs for the different types of disasters. And the goal of this study or aim was ultimately to inform the clinical practice and establish consistent standards that are context specific, but uniform enough to provide a base for future disasters. And this spans over to not only inform FQHCs, but also hospitals or other types of clinics or other locations or contexts beyond Puerto Rico. So we're trying to really optimize preparedness, recovery, and response for clinics and hospitals in a way that's consistent to the local context, the local environment. And to close off, I really want to highlight some strengths, opportunities, but also some challenges that we have encountered while studying the Puerto Rico health system. For challenges, first off, there's limited research on the Puerto Rico health system and on healthcare models within this context and just on this unique population in general, which makes it really hard to kind of justify your different findings, your different areas that you are studying. Second, there is limited publicly available data. So much of our research has required primary data collection, which in turn requires more time and effort. Third, there's cultural and language barriers, but this is why it's so important to have community and academic partners who understand that local context and culture and language, especially since a lot of them have lived these experiences themselves and can share identities with the population being studied. And finally, we always have to remember that we are studying groups that have been exposed to traumatic experiences. And so as part of our research, we need to be very mindful of not re-traumatizing groups and instead really helping them get through some of these experiences that they have lived. So moving on to strengths and opportunities, which I'd say there's many within this population. I'm listing out limited research once again, because that's also a strength. There's a lot of opportunities for research on the healthcare system for Puerto Rico, and there's a lot of space to design new healthcare models or adaptations of existing models for these settings, which are becoming more common with climate change, with growing chronic disease burden, and just the overall aging population throughout the US beyond Puerto Rico. And another strength is that local academic and community groups are very eager to partner. And so this really simplifies the connection with the health system and clinical care and opportunities to actually create sustainable, long-lasting impact on the health system. And with that, I conclude my presentation. Thank you very much for your time. I'm leaving here my contact and this QR code for anyone who wishes to contact me further.
Hi, I am Jessica Breland.
And I'm April Mohanty.
And we are happy to present today on equitable care for multiple chronic conditions, opportunities from the Veterans Health Administration. Start with our disclosures. The views are ours and don't necessarily represent the views of the Department of Veterans Affairs or the U.S. government, and we have no conflicts of interest. This is a roadmap of what we'll talk about today, starting with an introduction to the VA healthcare system. VA is the largest healthcare system in the United States. It provides care for about 6 million primary care patients every year. It's also an integrated healthcare system, so it provides mental and physical health care. And notably, veterans using VA tend to be older and have more conditions than other veterans and also than other people in the US. In terms of where care is provided, it happens in 3 primary places. Main facilities, which are often tertiary care centers in relatively large metropolitan areas. There are the community-based outpatient clinics, or CBOCs as we call them, which are like satellite clinics to help veterans access care closer to home. They have less specialty care on site. And then finally, there's virtual care. I always like to note that VA is and has been on the cutting edge of virtual care for decades. And as a result, was able to really rapidly transition to virtual care during the pandemic, and much of that care has continued. Women are the fastest growing demographic of VA users. They make up almost 10% of the people that VA serves. They tend to be younger than the men. They also tend to have more comorbid conditions. VA also serves people, unsurprisingly, from all racial and ethnic groups, as you can see here in this chart that's from the National Veteran Health Equity Report, which is an excellent resource for demographic information about veterans who use VA and also how patient experiences and healthcare quality differs across groups like age, gender, race, ethnicity, disability level, and other factors. And this is just one of the reasons that VHA is an important place to study health equity. It's a priority both for VA, but also for the federal government. VHA has a National Office of Health Equity that is committed to improving care for veterans, and quite importantly, for research on health disparities and health equity. All VHA users have access to physical and mental health care, which means that you can more or less control for, as opposed to just adjust for, access to medical care, which is often hypothesized to be a driver of healthcare disparities. And yet, unfortunately, health disparities remain in VA despite this access to healthcare. For example, Black veterans tend to have lower rates of hypertension and diabetes control than white veterans. So, moving into VA healthcare models relevant for multiple chronic conditions. The first one we will talk about is PACT. And next slide. It is really a foundational model for VA care. It's the VA's version of the patient-centered medical home. It typically includes a primary care physician, a nurse, a pharmacist, and a support staff. And the goal is to have every veteran assigned to a PACT team and then have veterans see that same team every time they come for care. And the PACT team can also serve as a point of contact to help coordinate specialty care, which is what makes it an important model of care for people with multiple chronic conditions. My work related to multiple chronic conditions has focused on a subset of patients who are at high risk for hospitalization. Around 2014, VA started to evaluate efforts to care for these patients using something called primary care intensive management, or sometimes called PIM, for these patients who on average had about 5 comorbid conditions. PIM built upon PACT by including additional team members and services related to things like recreation therapy and social work, with the idea of trying to facilitate even more comprehensive assessment, management, and coordination of care for these patients. And the approach was really supported by VA being an integrated system where all these different team members and services were in-house. Our early work suggested that it would be a good fit for the PACT model. And our work also highlighted some potential disparities. we found that Black patients in this high-risk group had higher rates of some negative social determinants of health, like homelessness and lack of supplemental insurance, which to me highlights the potential for these programs to address health inequities. However, despite these promising observational studies, when programs like PIM were evaluated in randomized designs, these programs didn't have the intended effect of reducing healthcare costs or use of healthcare services. That said, the patients reported that they had improved healthcare, health behaviors, and physical health outcomes, especially in relation to chronic conditions. So there are a few takeaways I'll highlight before turning it over to Dr. Mohanty. The first is that there's great value to doing this work in VHA because it makes it easier to do randomized quality improvement trials. Because of the National Electronic Health Record, you can actually assess the denominator of all potential patients who might benefit from an intervention. You can then randomize some of them, in this case to intensive management, and follow then all patients over time, which is how you get important null findings like these. There are also some gaps, as Dr. Wong, the author of the patient report paper, noted. Few of the trials actually looked at health behaviors as outcomes, which are, of course, important effects to assess. And then finally, I'll add that there's been little work on how these programs affect health disparities. For example, do they improve disparities because Black patients are more likely to have some of those negative social determinants of health, like homelessness, that could be addressed by this program? Or are those disparities actually just an artifact of bias in the algorithm that's used to identify patients in the first place, as has been seen with some commercial risk models in this population? And work in those areas is ongoing, and I hope will continue to be done in the future. And with that, I will pass it to Dr. Mohanty.
Yes, thank you so much. So another key model that we have leveraged to address chronic conditions in the Veterans Health Administration is the chronic care model. The chronic care model is an implementation model for quality service delivery that has been widely adopted by the Veterans Health Administration for over 20 years, and from which PACT is based. This model is designed to proactively improve healthcare delivery for chronic conditions such as hypertension and diabetes by optimizing 6 domains, including improved health system and organizational support, self-management support, delivery system design, decision support, clinical information systems, and integration with community resources. Strategies that optimize and integrate these domains are cost-effective and can improve patient activation, healthcare team responsiveness, health services, and treatment outcomes. And applying this model is useful for developing multi-level strategies that support a collaborative patient, provider, and healthcare system partnership. In consideration of the clinical information systems and computerized patient record system, or VA's EHR, is one of the most advanced systems in the US. CPRS, which was originally released in 1997 and supports care for multiple chronic conditions by placing virtually the entire VHA patient medical record at the fingertips of providers, including data from any VA facility. It also supports registries of patients and dashboards, which I will show momentarily, with chronic illness that enhance population-based management. In addition to CPRS, patients have access to tools to support chronic illness self-management through My Health eVet. In 2021, VA Office of Health Equity launched the Primary Care Health Equity Dashboard. This delivers national, visit, and site-specific data on HEDIS and SAIL metrics, including diabetes and hypertension control, displayed by gender, race, ethnicity, geographic residence, and they're working on area deprivation index as well. This tool can be used to activate QI champions to identify and work to address health inequities. Data are updated at least weekly, and key features include the ability to assess specific performance metric trends and the ability to drill down to patient outliers. This dashboard also includes a repository of equity QI resources, which are designed to help clinicians mitigate disparities at their site. Here's a closer look at the blood pressure control dashboard display by patient demographics at a particular center. Decision support tools like this are enabled by CPRS and are an example of the chronic care model at play. We observed, as many did, that inequities in multiple chronic conditions were especially apparent during the COVID-19 pandemic, as with hypertension, and opened the discussion for more innovative ways like virtual care to address and avoid exacerbating disparities. This figure was highlighted in our special report on hypertension and was from the October 2020 Surgeon General's call to action to control hypertension, including a call to address disparities. These multi-level modifiable factors operate from the individual patient all the way up to policy and environmental factors. Increasingly, race and ethnicity are understood to be a social construct that needs to be contextualized and complemented with information on social determinants of health and those that are modifiable. Another key model that we have leveraged to address chronic conditions in VA is the whole health model. Whole health care empowers the patient to take charge of their health and well-being. Incorporating patients' goals, desires, and values into their healthcare supports them in living their best life. And this effort is an extension of care for specific conditions or treatments of disease states into helping individuals achieve living their life to the fullest. One of the unique experiences of veterans in terms of multiple chronic conditions is that many have been exposed to toxic exposures, which have led to multiple chronic conditions such as Gulf War illness. There is still much to understand about Gulf War illness and chronic multi-symptom illness. Much of what we have learned can actually be applied to our understanding of long COVID. As with long COVID, we have seen racial and ethnic inequities, such as in this paper where we reported a higher prevalence of fibromyalgia among Hispanic veterans who were deployed to Iraq and Afghanistan. The War-Related Illness and Injury Center, or RISC, is a national program dedicated to veterans' post-deployment health concerns and unique health care needs. They develop and provide post-deployment health expertise to veterans and their healthcare providers through clinical care, research, education, and risk communication. As a tertiary care center, they partner with referring providers and their healthcare teams to support the care of veterans. The RISC is part of VA's newly designed health outcomes military exposure, formerly the post-deployment health services. VA is uniquely qualified to care for veterans with health concerns, including multiple chronic conditions related to potentially toxic exposures. Okay, so now we'll go ahead and summarize some of our key takeaway messages. So in summary, there are multiple models in the VA that to address health inequities for multiple conditions. And it's important to understand the limitations and opportunities with each of those models. VHA is an important place to address inequities related to multiple chronic conditions, with a special case of a military toxic exposure and Gulf War illness. A national electronic health record helps to understand national trends in multiple chronic conditions and coordinate care. Although more work is needed to collect and understand the roles of social determinants of health and modifiable factors across multiple levels of healthcare. VHA's coordinated and integrated infrastructure is important, but could be achieved in other settings within networks, for example. So with that, I just wanted to go ahead and say thank you for your attention, and we look forward to our Q&A session.
Thank you, Drs. Ali Rivera Gonzalez and Jessica Breland and April Mohanty. Thank you for your wonderful presentations. I took plenty of notes and I have some questions. And while I could start the conversation with you, I would like to invite those who are at the workshop to type your questions in the Q&A, and some of you are using the chat as well. So I would like to encourage you to do that. And let me start with some of the questions. I would like to start with Dr. Rivera Gonzalez about the healthcare systems in Puerto Rico. And one of the questions is that within in these 2 days, we have heard a lot about strengthening primary care, that primary care should be supported and strengthened to really offer all the services and the high quality of care that anyone deserves, and especially populations that are experiencing health disparities, how they could benefit from a stronger primary care. Within the context of what you presented about Puerto Rico and all the factors that you mentioned, the block grant and the local challenges in terms of the shortage of healthcare professionals, plus other nuances and intricacies of the different healthcare systems in Puerto Rico. How, in your assessments and in your work with the Primary Care Association, how do you see the strengthening of primary care being key for reducing health disparities or addressing the issues in a low-resourced setting like the Commonwealth of Puerto Rico? And a separate question is, within that concept of strengthening primary care and working with populations with multiple chronic conditions and patients that are aging, at some point they need referrals for specialists, because the nature is that there are going to be some complications of health that would need a specialist to be consulted. So within that context, how do you see the strengthening of primary care and within the constrictions of the resources, and what potential solutions in terms of referring to specialists do you see happening in Puerto Rico?
Yeah, really great question. First of all, I do think it's extremely important to prioritize primary care, strengthening primary care in Puerto Rico. Honestly, the shortage of providers is one of the biggest issues for both primary and specialty care, because we have very few specialty care providers as well, and they're usually in the more urban areas. So that adds another level of disparities in access to care. So by strengthening these primary care networks, I think that naturally creates a linkage to these specialty care providers, and it would facilitate if there was that care coordination between those different levels of care, which does not exist currently. So I would really like to see Puerto Rico move towards a more integrated system, something like what the FQHCs are already doing, but expanding it also to private health insurance and to private clinics. So the Primary Care Association could be that entity that really oversees all of this and establishes some type of centralized system where referrals would be made easier, duplication of services would be reduced if there's some type of, like what was mentioned before, like some type of electronic health record that could be implemented to promote that care coordination. I think that would be a very important first step. And then you add on all of the other dynamics. I'd say the public health emergencies really are a crucial component that we need to be considering in Puerto Rico, because they keep happening and they keep getting worse. And so this is something that has already been introduced into the FQHCs and into their care models. So they have implemented a task force, permanent task force, rather than an ad hoc task force for disaster preparedness. And so this also really enables that care coordination and access to care for people, because when disasters happen, you don't know what clinics are going to be open. It's there could be difficulties physically getting to a clinic or which doctors are available. So that
that disaster component, if it could be island wide, that would definitely benefit the whole dynamic of care coordination. But honestly, it all comes down to increasing provider retention in Puerto Rico, because if we don't have enough providers to serve the population, then referrals are just going to continue to go into low quality of care, where people have to be hours waiting for a doctor to see them, or months before they can see a provider, because there's so few of them. So there needs to be a governmental approach to increasing provider retention for practitioners that are being trained in the island and choose to leave because there's just not these good conditions for them to practice in. So that would be one of the crucial areas that should be addressed.
Thank you, Dr. Rivera Gonzalez. Very insightful and thought-provoking as well in knowing the challenges and what needs to be overcome. For Dr. Breland and Dr. Mohanty, you have presented probably a different situation on a system that has resources, that has very good coordination, in which several models of healthcare have been practiced, implemented, tested, yet you have mentioned that there are disparities, and you mentioned some examples about blood pressure control, diabetes control, on race-based differences. And you also mentioned unstable housing for some veterans. So considering the resources and the structure of the veterans health system, where do you see that in this very seemingly effective system, there could be some improvement to address these disparities that we can also learn and apply in low-resourced settings?
So just so I can understand again, your question is, what are the different social determinants of health that are of focus?
What could happen within the system, the VA system, to address the disparities that are still observed within the veteran patient population? You explained that this system, the healthcare is very organized, and there are many multiple models of healthcare, but yet there are disparities. So what could be happening? What could happen to address these disparities, and that we could also learn and apply to low-resource settings?
Yeah, I think early partnership with the communities that are impacted is very key. And also we work closely with our academic affiliates as well in the VA, to leverage those opportunities and ongoing partnerships, including with rural communities. So I think engaging in that kind of work where these communities really lead the work and help us innovate and basically meet them where they are, like the barbershop trials. And I think virtual care again is another really great opportunity for that, and engaging with veterans. And I think one of the great things about this dashboard that I highlighted earlier is that it does help us understand on a national level where the gaps are. I don't know if Dr. Breland wants to add anything there.
Yeah, I would just add that I think it's, the social determinants of health are often things that cannot be addressed by any one organization or institution, even as one that's as large as VA or VHA, and also affect people, from birth through the end of their life. So some of these disparities that we see among our patients could be due to the conditions that people had their early life experiences in. And so I think, in addition to what Dr. Mohanty said, which is key, which is working with the affected groups, it's important to think I think this has come up in a lot of panels about these larger structural changes that are needed so that, you know, all veterans have healthcare, but they have to have served in the armed forces at some point. You know, all kids, babies, young adults, people before they enter the workforce also deserve healthcare. So just making sure it's actually available to everyone across the lifespan, I think would probably go a large way to affecting disparities.
Well, thank you. And I have a follow-up question, actually, more about the characteristics of the VA patient population. And there is a question from the chat. Given that veterans have access to the VA system, what variables do you think contribute most to disparities in veterans with multiple chronic conditions?
Yeah, so, you know, certainly things like, you know, educational opportunity, food insecurity, neighborhood, you know, lived in whatever the environments that people live and work in. VA being national, I think it varies by the place and the condition, but I think, you know, those are all factors that are more at play because, again, veterans generally have similar access to care.
Well, thank you. I have a question for all of you, and it's about community engagement because you have mentioned it at different points in your presentations or your discussions. I would like to ask for examples. For example, in Puerto Rico, what examples of community engagement or community organizations or community projects that have facilitated or enhanced the access to primary care or any needed service or needed action in terms of healthcare. And similarly with the VA system, any examples of such community engagement?
I can start off. So I think community health centers in general, not necessarily just FQHCs, but community health centers have played a really important role in getting people access to care, especially in these like more rural areas of Puerto Rico that are in the center of the island and the mountainous regions, which are generally more impacted by these disasters, but also naturally have more shortages in access to care. So these community health centers, they'll often like host seminars or they'll do outreach or they'll have like promotora, like community health workers who go into communities and go house by house and literally create a profile of these communities. And so by establishing those connections with people, you are starting that linkage with the primary care. You are that link to them getting care because they already know someone's been contacting them. They feel like they're a part of something. They feel, you know, they're stakeholders in that process for that community health center. And so I think that's a good place to start for these communities that are often more at the margins than like urban areas would be.
Thank you. And from the VA?
The VA has basically the veteran service organizations, VSOs, and those are great opportunities to engage and, you know, build trust with veteran populations. And there's also, I think, an ongoing effort, at least here in Salt Lake City, of an Asian American, Native Hawaiian, and Pacific Islander center hub for research in VA with those populations. So those are just a couple of examples. I don't know, Dr. Breland?
Yeah, I think sometimes in VA, we also think about engagement of specific patient populations, since the healthcare that's provided isn't available to many members of a geographic community. So it's certainly encouraged, thinking about it from a research perspective, when you're writing proposals to have engagement from people who are actually affected by or going to use what you're working on. And I think for at least some of the ways you submit grants, it's required now that you have some form of engagement, just because it leads to better work.
Thank you. We have 2 more minutes for Q&A. I believe in the agenda it says 4:18. It ends our session. So I will ask one more question to each of you. In Puerto Rico, what do you think could set the stage or facilitate research in healthcare models? What would be needed?
I think interest would be the first thing. So there's definitely space already to do research on healthcare models in Puerto Rico. Again, the limitations I mentioned would be like the data. So if you were to do research in Puerto Rico, oftentimes you'd probably have to use primary data collection, unless you're able to get access to claims data, which for Puerto Rico, Medicaid claims data is free to access. So that provides an opportunity to study trends and apply healthcare models for multiple chronic conditions. But yeah, I think there's a lot of space already. It's just a matter of will, and establishing partnerships would be kind of the biggest recommendation. Having academic partners as well as community partners in Puerto Rico will help in that process of creating new projects studying healthcare models. So I would really recommend partnering with the University of Puerto Rico. They have many campuses and they have excellent researchers who are already very engaged with communities and often have a lot of knowledge already going into these research projects.
Thank you. And a question for VA. You mentioned a randomized trial that did not show a difference in some variables, but a difference in other variables. And I was wondering about the effect of time in the intervention, and it was about costs, no changes in costs. Do you think that if the length of the observation of the trial was longer, then that would have mitigated or actually seen the cost savings effect or not?
It's a good question. I don't know the answer. I mean, they looked at it at 1 year and they looked at it at 2 years, and didn't see much of a difference. I think it's actually an issue that comes up in a lot of equity or disparities work, of whether things that actually improve disparities and equities can be cost saving. If people aren't getting the care that they need and you then provide them access, it's potentially going to cost more. So I don't know, it's possible. I'm not actually sure if they're continuing to track it, but it is sort of a benefit of the VA data ecosystem that someone could apply for grant funding, perhaps, to look at it retrospectively, and you'd be able to look at the patients who got it and see if more time was needed for it to make a difference.
Well, thank you to all of you panelists of session 6. Thank you so very much for your presentations and answering the questions. Now we move to the last session, or almost the last session of the workshop. And I'll pass the turn to Dr. Yewande Oladende.
Wow, I can't believe that we're wrapping up the second day already. So it's my pleasure to introduce Dr. Sivan Spitzer, and Dr. Spitzer will be presenting. She'll be closing us out with a plenary session on the way forward. And her presentation is entitled Moving the Needle in Health Equity from academia high heels to real world muddy boots. Dr. Spitzer is a faculty member at the Israeli Faculty of Medicine at Bar Ilan University in Israel. So we're very delighted and excited to play Dr. Spitzer's presentation.
Good afternoon, everyone. Marhaba, ya'tikul afia. It's a pleasure to be here with you via Zoom. Early on in my academic career, in a workshop presenting to internists, I was asked if I felt like an alien. As the foreigner in the room and the sociologist among medics, just before I broke out in cold sweat, I actually had an aha moment that being an alien is a blessing, because as an alien, we're able to question concepts and constructs that are already in place. In my academic journey in health equity, that's something I've tried to apply. For example, questioning what are these 30,000-foot theoretical statements like culture of equity or infusing equity into the organization, such as a statement that can be found in class standards, what does that really mean in practice? And if I want to implement change, what are the knowledge and tools that I require? Am I bound by my own disciplinary background, by the context in which I was taught? And fundamentally, how can we translate equity from a value-laden concept to real-world action? Well, when we want to translate from value to action, we implement, we intervene. And interventions that have been implemented to reduce inequities in chronic disease have often implemented a linear path. We're taught to think linearly. But, when we look at the way that health outcomes are intertwined with social differences, with social problems, actually it makes health equity a wicked problem to solve because it's systematic, it's interlinked, and it cannot be solved independently through a singular intervention or a singular outcome or by a singular partner. So this actually poses a question of how do we address implementation? So I'd like to share with you a little bit of my journey in a real-world health equity challenge, which is diabetes in northern Israel. So to give you a little bit of background, about 9.8% of the population in Israel have diabetes, 20% have prediabetes, and we have the highest lower limb amputation rate due to type 2 diabetes among OECD countries. When we look at the rate of diabetes according to different regions in Israel, we can see that one significantly stands out, and that is the Northern Galil region. The Northern Galil region is Israel's social geographic periphery. It is comprised of about 17% of the country's population. More than 50% are Arab. It has the lowest income per capita in the country. It also has the lowest rate of physicians per 1,000 residents, and about 12% of persons with type 2 diabetes residing in the region have poor control and suffer from significant complications. In November 2021, the Israeli Faculty of Medicine, which is located in this region, launched the Russell Berry Galilee Diabetes Sphere, and Sphere is an acronym for Social Precision Medicine Health Equity Research Endeavor. This is the first initiative of its kind in Israel. It's a 10-year initiative, and it was set up with the aim of reducing diabetes disparities between the Galil population and the general Israel population, with the guiding paradigm to be socially accountable to its partner communities and impact their social, economic, and environmental development. Now, you may ask, why is Sphere's vision to impact social, economic, environmental outcomes and not just health? Well, as you know, the WHO has long determined that our zip code is stronger than our genetic code. And when we look at the prevalence of diabetes according to socioeconomic rankings of towns in Israel, and all towns in Israel are ranked on a 1 to 10 scale, you can see that the poorer the town, the higher the prevalence of diabetes. Well, this conception required building new partnerships from the get-go. And as a medical faculty, our immediate partnerships are often that of healthcare systems, for education purposes, for research purposes, not so much with municipal government. We began with 5 cities, working across 5 cities when we launched Sphere in November 2021. Today, we work in over 23 cities with over 600,000 residents. This project is now implemented as a national project with the Ministry of Health, and we're working almost with 70% of the country's Arab communities and over 50% of the region. So operating at scale required us to really think from the get-go. how do we create a wicked problem approach to implementation? And how do we understand what may be multiple costs so that we can create a problem-solving path for moving the needle and creating sustainable solution? Well, in essence, it was actually going back and revisiting those questions that I posed earlier. For example, translating the question of culture of equity. What kind of costs are there? So when we look at these questions, we can actually identify that there are organizational costs and benefits, there are social costs and benefits, economic and personal costs and benefits. And to engage in communities in the real world, to be a true partner to equity implementation and not focusing on a singular outcome or a singular partner, it means that we have to look and translate these organizational, social, economic, and personal costs to pragmatic actions such as creating the business case or operationalizing equity so that the community can take action with us, building the right team, and ultimately building trust. This requires intertwined actions, again, all with a cost and benefit, that before we even implement, we build this shared platform for interventions. So what does it look like real in actions, right? When we translate this to action and not just keep it as at words. So the first step was approaching the community. And I would say specifically community leaders to partner with us because, while we may think that they'll ultimately want to partner, often the question that is posed is, what does my community get out of this? And I would say that the challenge is even greater because we need to convince them that health is part of their responsibility when they're not responsible for the provision of health care. So we wanted to see how can we change their perception? And that was by making the business case. Well, when making the business case, we can often turn, for example, to patient cost of illness models. But there isn't a municipal cost of illness model. And so we thought, well, we need to find the municipal cost access. Remember the slide I showed earlier. The poorer the town, the higher the prevalence of diabetes. And when we looked at the data, we saw that 50% of persons with type 2 diabetes residing in these towns receive welfare support. In Israel, when you receive welfare support, that means you're entitled to a reduction in your residential tax, a discount in your residential tax. However, the poorer the town, it's not only the higher prevalence of diabetes, the poorer the town, the more residential tax is a significant source of income because there is no industry zone. So these towns rely mostly on residential tax and government funding. So from understanding the social and economic costs, we were able to calculate a municipal cost of illness and the loss of annual residential tax due to diabetes. And this enabled us to trigger a sense of urgency because, as you can see, annual income loss ranked all the way from 2% to 12%. So now I have leadership listening. But if you want to implement, it's not just enough to get leadership to listen. You want partners to implement with you. And that means you need to invest in the organizational and social costs to train the community to understand the implications of health on their everyday policies and actions. So we created a multidisciplinary training and mentoring for municipal personnel so that they can actually partner with us. Now, training is not the only cost because ultimately you want to help them take action with you. You want to operationalize tools, you want to operationalize equity, and you want to give the community tools to take action. Well, one way is data. Within the healthcare system, we often see a lot of data, but towns, especially those who don't provide care, don't see this data. So we co-designed unique dashboards with our partners that enable them to really link up municipal and health data to understand, for example, where they have hotspots within neighborhoods. And understanding these hotspots are not only in terms of the prevalence of diabetes or poor control of patients, but actually what are the existing community infrastructure to facilitate interventions? For example, are there places to exercise? Are there places to buy healthy foods? So that we can together as partners prioritize, and they would have the tools to make wise decisions where to intervene, even when Sphere is not partnering with them. To do all of this also required a large investment for Sphere itself in terms of building a transdisciplinary team. But leading such a team has a personal and social cost because our team is made up of Jews, Arabs, Druze, Muslims and Christians, people who are religious and those who are secular. And for us to be authentic to our community, we first have to be authentic to ourselves. And that means that as a leader, I need to facilitate and encourage difficult conversations within my team. For example, what does it mean to be a Palestinian Arab who resides in Israel during the time of the Israeli-Palestinian conflict with family members in Gaza? Just as much as what does it mean to be Jewish and have lost family members in October 7th, both of which have happened on my team. And, you know, it doesn't just stop there. It's not only facilitating conversation within the team, but also as a PI, as the principal investigator, having the personal cost to really break power differential. For example, when going to meetings with my partnering community, or even within my team when everyone speaks Arabic and I'm the only non-Arabic speaker in the room, not have them all change to Hebrew so I can understand, but rather learning Arabic myself so that I can break that power differential. I would say that also working with communities has sometimes a social and organizational cost that we cannot foresee. And this is critical for building trust before we even implement, because sometimes goals will shift. And, you know, and again, using the conflict as an example, our partners turned to us and said, you know, we are disadvantaged communities. We don't have the data. We don't have the infrastructure to manage data. And we don't know how to manage health in emergency situations. So this isn't part of Spear's agenda. We focus on diabetes. We focus on obesity. But it was clear that this was something that we have to be attuned to. And so we created a platform for our communities to be able to collect and monitor health data with our assistants. And for example, for the first time to show decision makers at a national level that we had a lot of clinics in these disadvantaged communities that didn't have any protected areas. Of course, this was also given as information to local residents so they would know where care is provided in times of war. So now that I've kind of show you how we've made the business case, trained community partners, build trust both within the team but within our partners, you know, it was clear that we have these multiple costs to create a problem-solving path, and that now we're ready to implement different solutions. So what does these solutions look like? And I'll give just a few examples, part of the many interventions that are currently running in Sphere towns. So one intervention or one example is reducing the conversion rate from pre-diabetes to diabetes. And within our towns, as I said earlier, we had a higher prevalence of diabetes. It was clear that there was a vicious cycle, that, you know, there was not a large investment in terms of prevention of the disease. And we decided to work together with our municipal and local healthcare providers to create a community-based infrastructure so that the patients at risk, the residents at risk, are identified. And we're able to raise awareness not just through local healthcare providers, but also through local religious leaders. For example, we've trained over 360 imams throughout the region so that they can also provide religious guidance and raise awareness, for example, for residents at risk. And in a feasibility trial, we saw that running such an intervention with a community platform in a town, we were able to reduce the conversion rate from 6 to 3%. And now this is currently being implemented at scale throughout our towns. Another example is, what do we do in terms of poor control? Now, I mentioned that 12% of Israel's patients in the north had poor control. Within Sphere intervention cities, we saw that sometimes this increased to 15 and 25% of patients with poor control. And there was low adherence to annual checkups. Some of it due to access to care. For example, it's difficult to conduct eye exams because of a shortage of places to conduct such exams in the region. So with our partners, both healthcare and community, we set up and built a one-stop shop mobile unit. And this is a really interesting example. It doesn't only facilitate access to care, but having a community partner with you, of course, then you have the logistics to identify the infrastructure within a community to bring this mobile unit to a patient's doorstep, so to speak, right? Where do we have the hotspots? But I'll also give maybe a little bit of a different angle, and that is how can we look and work with these communities to actually make sure that they're better represented in clinical trials. A one-stop shop mobile unit is a wonderful way to collect clinical data. Because of the poor infrastructure, most of these disadvantaged communities in Israel are underrepresented in clinical trials, especially within the Arab community. So working with our communities, and we're not only improving care access, but we're also really creating, for the first time, a new infrastructure to collect data and increase participation of these communities in clinical trials. And one last example of an intervention that uses this platform is to increase and reduce the disparity, increase the prescription of and reduce the disparities we see in GLP-1 SGLT2 inhibitors in the northern periphery. When we looked at the data, we saw that there's a 30% disparity between the north and the country. Now, it's important to note that within Israel, we have a national insurance, and there is a very good health basket. So we would think that all patients should receive this care. So one aspect is that patients aren't knowledgeable enough of what they should be getting. There isn't simplified material in plain language, but it's not only in plain language. In Israel, we have 4 official languages. We have Hebrew, Arabic, Russian, and Amharic, and we actually only have the information in Hebrew, and even that is not in plain language. So that was one way to address. The other is really to address that we notice that there is underprescribing. Now, when within healthcare systems, when we overprescribe, that's often regulated, but underprescribing is not regulated. And it was clear that this underprescription required that there is a different intervention within the community, and that was for educating local physicians. So to actually improve prescription utilization, we set up a very simple calculator that would help them know how to prescribe better GLP-1 receptor agonists and SGLT2 inhibitors. So kind of as I come to concluding my talk, I'd like to end with a few take-home messages. And one is that moving the needle on health equity isn't linear. It's really not looking only at disease-specific outcomes, which will often be distal, but it really requires us to really think of what are additional metrics, different metrics that we need to look at to move the needle on populations. It also requires us to identify pragmatic actions and not only interventions. We're pretty good at, and we're reasonably doing well in terms of interventions, but the actions that we need to get there, are just as important and rigorous, and they complement interventions. And this is an area that is really understudied. To create true community partnerships, we require a transdisciplinary team. And authenticity within your team is having those hard conversations. And you need to have those hard conversations within your team to be able to have them with your community partners. You need to think of sustainability from day one. Understand the costs and the benefits so that you can really identify your building blocks for the short, the medium, and the long-term processes. And at the end of the day, working in the real world is being able to navigate between academia high yield and muddy boots. Thank you. תודה רבה. שוכרן כתיר.
All right, Dr. Spitzer, if you can please come on camera, that would be awesome. Wonderful. Thank you so much. That was an excellent presentation. So at this time, I would like the audience to start putting their questions in the chat or in the Q&A. Okay, I thought I had a question. In the meantime, I'll start off with a question of my own. So you really talked about, leading a transdisciplinary, culturally diverse team and how that truly takes special skills. And that before you even go to engage with the community, you really have to be true to yourself. And that way you can then connect with the community. So I'm just thinking about, how do you, can you talk briefly about how you operationalize and even sustain, the team, the multidisciplinary team that you work with within the context of Sphere?
So I think I would divide my answer into two parts. So transdisciplinary across disciplines. So I think I showed a brief slide of part of my team members, and you see that we come from really very varied disciplines, from city planning to economics to health, public health and health promotion. And of course, we have clinicians on the team as well, endocrinologists and primary care physicians. So I think it's creating a common language first across disciplines. We're very bounded in the way we're trained. Often we're also trained in silos. We're not only, operate in silos and giving care, but we're also trained in silos. So I think as a first step, professionally, it's also creating a common language across disciplines, and that everyone understands different, right? So I didn't have a background in city planning, but I had to learn the basic concepts of what it means so that I would be able to interact and understand the moving pieces. I think the second part is a bit more complex. And I think, your social skills as a leader, your ability, I think, to make room for different opinions. And they really vary across my team members. I talked very briefly about having the hard conversations, but I think it's not only having the hard conversations, it's first allowing for the space on the team and team meetings, acknowledging that this has to be part of our day-to-day because it's going to meet us in the field. If we're not able to have it as part of our own day-to-day operations, it's not going to, we're not ultimately going to be able to have these conversations in the field. And they need to, when we're working in the field of health equity and, with my own personal background of being a white woman who's not necessarily from an underprivileged or background, as some of these communities may view me, I have to be able to understand and have these hard conversations on my team first. So I think it's making a conscious space as part of the team meetings of having these hard conversations and addressing the issues.
Thank you. That's great. So another question I have is just hearing you speak and just reflecting back on some of the previous sessions that we've had. So, we talked about the multiple chronic disease centers, how they have to collect CDs, common data elements. And I'm just reflecting back on your presentation when you talked about the shared platform for interventions. In your work, do you have to collect CDEs or something that's like CDEs at all?
So yes, we do. I think there were a lot of conversations about data, access to data collection, especially when you're working in such underprivileged. So the short answer is yes. We have good access to healthcare data. I have to say that we have electronic healthcare data and with good access, but unfortunately, we don't have good access to social determinants of healthcare data. So I see you wanted to make a comment.
Well, I had a second part to that question. So
okay.
That's the second part of it. So when you talk about not having, not collecting social determinants of health data, I guess that's where the next part of this is going. So in your work, are you trying to collect some of the data? And if so, I just wonder, are there some challenges when you work with the different communities? Because just like you showed, the languages spoken, the communities are very different. So are there some challenges in trying to do this work and in trying to collect some of that data from the different communities you work with in Israel?
Oh, definitely. But I think it's also taking, or at least from our perspective, it was having the community partners collecting data with you, right? So instead of you collecting data yourself, and that was part of the training, it gives, I think, the community the skills to then view data itself, rather than having data top down where communities rely on data from an external entity such as academia. It's actually giving the community tools. And by having community partners collect data with you, it enabled us to get to a lot of data that I don't know if we would have been able to collect ourselves. So that was really a strategy that we had chosen. Again, building the platform before we intervene, thinking of the missing parts, and actually how can we really create a true partnerships where community is really collect. So that was one way in terms of data collection, because we're really talking about a poor infrastructure and a lot of data collection that needs to be done together. It's also understanding what this data will serve the community and how it's their data. So ownership of data. I think that's another issue we don't always take into account when we work with communities. We often think of the data, especially coming from research institutions, that this is our data. This was very important from really the first step, that this is the community's data. It's there for the community, for them to use. And we're trying to work with them to help them understand and reduce the inequities that they see, but this isn't not our data. So I think that was another way to make sure that they understand the partnership and get them to work with us.
Okay. I have one very quick question and I'll pass it on to my colleague, Dr. Warnum. So when I think about what you said, one of the things you said, and I think that we've heard it echoed already in terms of thinking about sustainability from day one, right? As you're writing that grant and you're planning your research, thinking about sustainability. So very briefly, maybe in one quick minute, can you just tell us how, practical ways that one can start thinking about sustainability from day one as you plan out your research? You kind of alluded to one or two, but I just wanted you to talk very briefly about it.
Yeah. So again, sustainability, I would say there's two parts to it, right? Is what you're leaving behind. So to me, that's a big key in sustainability. Sustainability for your interventions is what are you leaving behind? And that you need to be cognizant of from this first day you're operating in the field. What will happen once funding runs out? Can this continue without you? And I think that has to be there from day one. I think another thing is really looking at the economic effectiveness and the cost effectiveness of your intervention. Again, from day one of planning, what does that mean, and how, again, in a limited resource area with limited budgets, can this be sustained if funding runs out? So to me, just two quick points of what sustainability can look like and what you need to plan even before you start to implement.
Thank you so very much. We really do appreciate your time and you making time out to be with us today. With that, I'll pass it on to Dr. Warnum.
Thank you so much. Dr. Villasanta, do you have any final comments before we go to reflections and thank yous?
I only want to acknowledge all the personnel, the staff, our colleagues that collaborated with this workshop, and would like to read their names again as I did this morning. I would like to acknowledge, and some of them are not, I see some names, but I don't see all the names, but it's going to be recorded, so they're going to hear their names again. So Dr. Lynn Padgett, Dr. Dolly White, Dr. Carolina Solis-Sanabria, Dr. Radha Dyer, Dr. Shilpa Amin, Ms. Simran Sidhu, Dr. Nancy Jones, Dr. Priska Mujuru, Dr. Vanessa Marshall, Dr. Michelle Dose, and Dr. Crystal Barksdale. Thank you for your participation, collaboration in several aspects of this workshop, especially as moderators of sessions and breakout sessions. And thank you to Yawande and Sandania for all their hard work in coordinating the workshop, along with our contractor, SIDM, and our colleagues from OCPL and the administrative office at NIMHD. I now pass the microphone to Sandania. Have a great afternoon, everyone.
Thank you, Larissa. Yesterday, we kicked off this wonderful workshop by discussing challenges of conducting research of multiple chronic conditions, innovative models of care, how to advance health equity, and brainstorm potential solutions and opportunities for optimization. Today, we crescendoed by discussing common data elements, the overlay with the NIMHD Health Disparities Research Framework, just touching on each of the social determinants of health as well as global health and how they impact the work that we do and the care that clinicians provide. We discussed conducting research of multiple chronic conditions in the rural South, as well as in Puerto Rico and in the VA healthcare system. We discussed the opportunities and challenges of coding EHR encounters for multiple chronic conditions research, culturally congruent healthcare to reduce health disparities in Indigenous populations, innovating flexible models to address multiple chronic conditions and randomization of patients in projects, trials, and research, building effective multidisciplinary teams and research teams to address multiple chronic conditions and mitigate health disparities. We also discussed effective research strategies at community levels. We talked about cancer and morbidities, especially in special populations, and how the treatment of multiple chronic conditions to include cancer is paramount. We talked about racial disparities in diabetes-related care among cancer patients and evaluating the equity in cancer care overall. We even discussed concrete analytical approaches to doing this complex research, natural language processing to get at race and ethnicity and missing EHR data, potential solutions for data harmonization, especially with structural determinants of health. And finally, we questioned the status quo to move the needle in the research of multiple chronic conditions to include addressing implementation research, differential methodologies, and pragmatic actions in interventions. With that, on behalf of NIMHD, the workshop chair, Dr. Larissa Villasanta, my co-chair, Dr. Yewande Oladinde, each of our presenters, our esteemed colleagues, moderators, and every single attendee on this call, we thank you immensely for your participation, contributions, and most of all, the energy that you have shared with us to continue to move the needle to optimize the health and healthcare of people living with multiple chronic conditions. Thank you. Have a great night.